having knowledge of that what are the presenting symptoms is important to have a think about that this particular woman or girl may be suffering from ovarian cancer. So nowadays, at least in our hospital, we are getting 2 or 3 patients of ovarian cancer of any age in each of our units. So there are 6 units in Queen Mary. So the incidence maybe has risen, or the number of patients who are approaching for treatment, they have increased. So one should have a basic idea that what has to be the clinical features, symptoms, signs that a doctor should think of suspecting that this woman or girl is suffering from ovarian cancer. So it is the second most common gynecological cancer globally. In India, we know that cancer cervix is the commonest cancer. And the second most cancer globally, means worldwide, is ovarian cancer. The important is that early, like I said, early stage disease. I mean, if the ovarian cancer is diagnosed at an early stage, it is potentially said to be curable because surgery is there, many options are there. So early stage disease is a potentially curable disease. Early identification but relies on symptom recognition in at-risk individuals, because while we take history and we examine the patient, and if the woman is at risk, then definitely early identification is important. But the main drawback of ovarian cancer is that it presents very late. Usually, when the woman presents to a doctor, it is at an advanced stage disease. Okay, so the commonest way of presentation is advanced stage, and is the commonest cause of death in gynecological cancer. And the most important thing that we should also know that there is no robust screening protocol or method worldwide. ऐसा नहीं है जैसा कि हम लोग कैंसर सर्विक्स में पढ़ते हैं कि उसका एक स्क्रीनिंग मेथड है ना, इंडोमेट्रियम के लिए एक स्क्रीनिंग मेथड है, बट फॉर ओवेरियन कैंसर वी डोंट हैव अ रोबस्ट स्क्रीनिंग मेथड कि आप उसका एनुअल पेल्विक एग्जामिनेशन कीजिए और यू वांट टू डू एन अल्ट्रासाउंड. सो देयर इज no such robust screening method to screen a woman that she is a woman suffering from early stage disease. Okay, so coming to history taking, like in every case we used to take history and then we examine the patient. So history taking is very important because say any age is at risk of ovarian cancer, but age more than 40 is a risk factor, infertility is a risk factor. Then a change in pattern in a premenopausal woman or postmenopausal bleeding may be one of the symptoms of ovarian cancer presentation. And if a woman has used oral contraceptive pills for more than 5 years, it has a protective effect. Likewise, if she has a past history of breastfeeding more than 12 months, again it has a protective effect. So I have to take history of breastfeeding, I have to take history of use of any contraceptive, especially OC pill. Family history of ovarian or related means breast cancer or intestinal cancer puts a woman at risk of say ovarian cancer. And if there is a history of cigarette smoking, the woman is at high risk. So in history, we should look for all these factors which are associated with increased risk of or a protective effect on the ovarian cancer. अब symptoms क्या होंगे? So majority of these patients, they present to us with a non-specific symptom like a vague abdominal or pelvic pain, abdominal fullness or bloating, breathlessness may be there, cough may be there. If there is a distended abdomen because of ascites, then difficulty in eating or feeling full, जल्दी ही पेट भर जा रहा है, भूख ही नहीं लग रही है, ऐसा लग रहा है जैसे पेट फूला हुआ है, bloating है, distension है, urinary urgency, frequency, but the pattern frequency of these symptoms are important. अभी तक तो ऐसा नहीं लग रहा था, लेकिन अभी कुछ महीनों में ऐसा लग रहा है, पेट जल्दी भर जा रहा है, abdominal bloating है. So we should not say that ऐसा होता है. We have to think about that these may be early symptoms of a woman who is having ovarian neoplasm. So symptoms are non-specific. Now what is the frequency of symptoms? The commonest way of presentation is having abdominal, abdominal bloating, abdominal fullness, distension. It is observed in 77% of the women. Next is the gastrointestinal symptoms. Pain may be there in 58%. Constitutional, anorexia, weight loss may be there in about 50%. Urinary symptoms may be present in about 34%. And pelvic, like pelvic discomfort or heaviness in pelvic area, it may be observed in 26% of the patients or women. Now there is a concept regarding symptom index. Symptom index. Now what is it? It helps in evaluating the patients with early ovarian cancer. और symptoms क्या क्या इसमें हम consider करते हैं? Pelvic or abdominal pain, increased abdominal size or having abdominal bloating, difficulty in eating or feeling full. So symptom index is considered positive if it is new to the patient within past 1 year and these symptoms happen more than 12 times per month. तो क्या क्या है? Pelvic or abdominal pain, abdominal size increased हो गया, abdominal bloating, difficulty in eating, and if it is present throughout the month, say, then the woman is having a high suspicion of suffering from ovarian neoplasm. But again, it is not yet recommended for clinical use. Examination. So once we take history, like in any patient, we have to examine the patient. And examining has to be done a thorough general examination, the abdominal examination and a pelvic examination. So it is very important finding. And in addition to all these, breast examination as such is a part of examination finding. So we have to examine the breast. Then lymph nodes has to be palpated, especially the supraclavicular, axillary, inguinal, and likewise we do in all patients per abdomen examination, doing a per speculum examination and doing a PV examination is very important. So here I would like to emphasize that many of the times we come across the patients who visit a doctor with symptoms, and being a woman, the doctor is not examining the patient physically. So physical examination of a patient is very, very, very important. Okay, so we have seen that the patient has complaint of discharge and the patient is prescribed medication without doing a simple PS examination. So for any woman with complaints specifically to the menstrual pattern, to the discharge pattern or to the abdominal fullness, bloating, we should do a thorough examination of the abdomen. Doing a PS examination is mandatory in all the patients in whom we can do, and doing a PV examination. Even if the patient is has not come to my OPD and I am examining the patient, like doing a PS and PV examination, and on examination I am finding a adnexal mass. मुझे ऐसे ही मिल गया, पेशेंट तो दिखाने वो किसी और कंप्लेंट से आई थी, लेकिन जब मैंने उसको एग्जामिन किया तो मुझे पीवी में एक एडेनेक्सल मास मिल गया. So next I will write her ultrasound. And depending upon the findings, I will have a suspicion that she is having ovarian neoplasm, may be benign, may be malignant. So my thought is for each and every woman who is coming to doctor for any gynecological complaint, our duty is to do a clinical examination, which we do not do. So prescription writing has to be done only after clinically examining the patient. Now, what are the findings which are suspicious of ovarian neoplasm? Like if the woman is having thin build, she is having abdominal distension, there is ascites, then on doing a per abdomen examination, there is a feeling of mass in the abdomen, then there is lymphadenopathy in the groin area or in the supraclavicular area. I will do a PS examination, I will do a PV examination. And if I get an adnexal mass on pelvic examination, I have to think for further investigations. Presence of nodules in the pouch of Douglas on vaginal examination or say rectal examination will make me suspect that either she is suffering from endometriosis or she is suffering from malignant neoplasm. Because these are the two conditions where the woman is having nodularity in the pouch of Douglas. So yesterday we had a patient in OPD who was 65 years old, and she was referred from somewhere else with a huge abdominal mass. So on clinical examination, she had a huge abdominal mass, but there was no ascites. The mass was clinically, it was a smooth surface, though firm in consistency, mobile. And on PV examination, we were able to feel the lower pole. There were no nodularity in the pouch of Douglas. And one most important thing is also is absence of a bilateral pedal edema. So till now, till she is investigated, our clinical impression will be a benign neoplasm, because usually if the nodularity is present in the pouch of Douglas, it points towards malignant neoplasm. प्रेजेंस ऑफ बायलेटरल पीडल इडमा है तो मलिग्नेंट न्यूप्लाज्म की तरफ जाता है ज़्यादा. अगर एसाइटिस है तो वी विल थिंक एट द टाइम ऑफ एग्जामिनेशन कि शी इज सफरिंग फ्रॉम मलिग्नेंट. आई एम नॉट सेइंग कि इट कैन नॉट बी मलिग्नेंट, बट द फाइंडिंग्स ऑन क्लिनिकल एग्जामिनेशन मेक मी थिंक अबाउट दैट probably she is having a benign neoplasm, but again we have to investigate her what is the cause. So that is about the clinical findings, the symptomatology of the ovarian neoplasm. Like the woman, we have to take history, we have to examine the patient, and what are the findings that we have to ask in history, and what are the findings that we should see while we do general examination, while we do a abdominal examination, while we do a PS and a PV examination. Okay, so any queries? If the woman is having a sex cell tumor, like a androgen secreting tumor of the ovary, she will have amenorrhea. If she is having a estrogen secreting tumor of the ovary, she can have abnormal bleeding pattern. Okay, so a woman in a say postmenopausal can present bleeding because of this hormone secreting tumors. So a recent change in pattern is important. So that doing a pelvic examination will give a clue to you. So if the girl or the woman is presenting with a change in the bleeding pattern, definitely you cannot do a PV examination in a girl, but again you can do a PR examination. You can do a rectal examination. And on getting the ultrasound, we will come to know that there is a mass in the adnexa, and what are the features which suggest that this particular girl or a woman is suffering from neoplasm, benign or malignant. There are findings which make you suspect कि ये benign है कि ये malignant है. Okay, so that can be one of the presenting features. So once in OPD a patient has come, I have taken the history, I have examined the patient, and I am suspecting now that she is having adnexal mass ovarian neoplasm. Now what are the testing modalities that I have which I will advise to the patient to confirm my diagnosis? क्योंकि अगर diagnosis confirm नहीं करेंगे तो उसको treatment क्या advise करेंगे? So I have to advise her certain sort of tests which is required to confirm the diagnosis of ovarian neoplasm. So the diagnostic modalities can be imaging modalities, और second है tumor markers. These two will help me in reaching to the diagnosis of the type of the ovarian neoplasm. So imaging studies, we have ultrasound, whole abdomen and pelvis. In addition to ultrasound, if the findings are not clear on ultrasound, or when the patient is being planned for surgery, CT, whole abdomen and pelvis contrast enhanced is required, and sometimes we also require MRI abdomen pelvis. Sometimes PET scan is also required, but definitely these are the investigations which can be done only after a basic ultrasound is done. Okay, so ultrasound is first non-invasive imaging modality which is available everywhere. And if a person who is experienced enough to do ultrasound will write that there is a adnexal mass of this particular size, consistency, or solid or cystic, and what is the appearance ultrasonologically. So he or she can give us a clue that this particular mass is present in the ovarian's area, and the ovary is not visible separate from the mass. So many of the ultrasound reports that right side of ovary is not visible. There is a mass and the ovary is not separate from the mass. So we suspect that this particular mass is arising out from the right ovary. And tumor markers are there. So ultrasound of the abdomen and pelvis, transabdominal, and the person who is experienced in doing transvaginal can supplement doing a say TVS is the basic investigation, as I said. And if the machine is having color Doppler, usually आज के समय में सारे machines में color Doppler होता है, so the ultrasonologist puts a color Doppler on the mass. And if the mass is having a high vascularity, it points towards malignancy. Benign neoplasms, they are not so vascular, but malignant ones will be highly vascular. So adding color Doppler to the that suspected adnexal mass will help in differentiating towards benign versus malignant. And again, I have to document the uterus, the other adnexal areas, diagnose the presence of adnexal mass, and ascites is present or not. Sometimes thickening of omentum or presence of lymph nodes, they are also documented on ultrasound. What is the say liver is normal, or there is any other deposits present over any area of the liver or spleen or omentum or anywhere in the peritoneal cavity. So a good ultrasonologist will document all the findings if he or she comes across an adnexal mass, and that adnexal mass is having a high vascularity, giving him or her a suspicion of ovarian neoplasm, then he will document or she will document those findings and will write that findings are suggestive of ovarian neoplasm, malignant. Malignant शब्द उसमें लिखा जाएगा, not benign. तो क्या क्या फीचर्स हैं? So a clinician should also know that what are the features on ultrasound by which we will say कि ये benign है और ये mass malignant है. So for possibly benign lesions, usually that mass will be round or oval in shape, anechoic fluid filling the cyst cavity. It will have thin wall. There is no impairment of sound transmission through the mass. There is no loss of signal from the tissues behind the cyst, and there will be no internal flow with color Doppler imaging. ये अभी picture होगा इसमें. Like for example, this is a ultrasound, and it shows that this is a adnexal mass. Okay, and in the mass there is a spectral appearance, ground glass appearance. This picture will probably tell me that this is an endometrioma, but whether it is endometrioma or not, I will take history, I will do examination, and when ultrasound is done, there is a mass, and on putting this Doppler window, the vascularity is only on the periphery. It possibly, and it is a round in shape, though it is filled with a say material, probably this particular diagnosis is of a benign endometrioma. Okay, so the shape and what is filling inside is important. So here it is TVS with color Doppler image of left adnexa showing a benign endometrioma of the left ovary. There is no flow within the cyst. However, blood flow is demonstrated within the wall of the cyst. Okay, so a Doppler has given me the clue that this particular mass, though it is not appearing cystic, is possibly benign because it has no internal vascular flow. है ना? अभी अब इसमें देखिए, इसमें भी ऐसे ही मास दिख रहा है. This particular mass is again similar. It has a round glass appearance. But the important thing is that when the Doppler gate or window is being put, just see the vascular areas inside the mass. अंदर कितनी vascularity है. So wherever there will be malignancy, there will be neovascularization. So having increased vascularity is one of the important findings of malignancy. पिछले में भी ऐसा ही कुछ मास दिख रहा था, है ना? पिछले में भी जो मास दिख रहा था वो ऐसे ही था. इसके अंदर it was a ground glass appearance. It is not a free say fluid filled cyst, है ना? But here the vascularity is minimal and it is simply on the wall जहाँ से vessel होगा. Otherwise the entire area is avascular. But on this the vessels are going inside into the mass. So presence of increased vascularity, especially inside the Mass is suggestive of a neoplasm, malignancy. Impossibly benign, the shape is round or oval. It can be a fluid filling the cyst cavity, the wall will be thin, and there will be no internal flow with color Doppler imaging. ठीक है? Possibly malignant में क्या होगा? Solid component will be there. Okay, and it can be in a nodular form or in a papillary form. A solid component with blood flow is the most important feature of malignancy. And septations, if present, they will be irregularly thick, and the thickness will be more than 2 to 3 millimeter. And the wall thickness alone is not a reliable feature for distinguishing benign from malignant ovarian masses. So that we will see later. Like here, like in this, here are the thick papillary projections inside this particular cystic area. So presence of this papillary projections inside a cystic area having an increased blood flow on Doppler will make the ultrasonologist or myself that this woman is suffering from malignant neoplasm, not benign one. So ultrasound will give me a clue. So the ultrasonologist will give me a clue. The size, the internal contents, the thickness of the wall, septations present है कि नहीं है, और अगर है तो उनकी thickness क्या है, कोई solid papillary projections हैं कि नहीं है, and about the blood flow. Depending upon these and the presence of ascites or having omental caking, that will make me suspect कि नहीं इसमें ovarian cancer है. This is a malignant neoplasm and this is a benign neoplasm. Now confirming more, we have different analytical like indices, and one of these is the IOTA analysis, which is International Ovarian Tumor Analysis, जिसको हम लोग simple rules बोलते हैं. कभी कभी confusion हो जाता है कि benign है कि malignant है, because if it is a malignant one, I have to think about doing staging laparotomy in the patient. Okay, so it has 5 features of benign and 5 features of malignant. जैसे compare किया गया है, B is for benign features, M is for malignant features. So benign means usually the benign cyst is a unilocular cyst. Okay, it is a unilocular cyst. एक बड़ा सा cystic area है, उसके अंदर fluid भरा हुआ है. That is benign. Just see here, it is again a cyst. But again the contents which is inside is a solid. Again it is not, this one is regular, this one is irregular. Okay, so these are the M1, and the M1 is the B1 is the unilocular and M1 is the irregular solid tumor. Second में क्या देखते हैं? Presence of solid components. Agar in case there is a unilocular cystic and there is a solid component inside, again this particular component is a very small, tiny component. But in malignant, in M2, there will be M2 feature here is the presence of ascites in the patient. Then in B3, benign 3 feature is the presence of acoustic shadow. इसका मतलब ये होता है when the ultrasound beam is going, what is there? This particular area is causing a shadow behind. इसको बोलते हैं acoustic shadow. This is a feature of benign neoplasm, which is not present in malignant one. M3 का मतलब जो malignant 3 feature है उसमें क्या है? Presence of at least 4 papillary structures. Like inside this particular ovarian cystic area, adnexal cystic area, 1, 2, 3, 4, 5 papillary projections are there, and they are thick and they are solid. So this is pointing more towards this is a malignant feature, not pointing. Again, benign 4 is if there is an adnexal mass and it has a multilocular cystic appearance like this, but again the largest diameter will be less than 100 millimeter, and here it has again a multilocular appearance, but again solid areas are there, the wall thickness is more, and here the diameter will be largest, will be more than 100 millimeter. Then benign 5 is no blood flow, like there is a ovarian, this is an adnexal mass, But again when I put Doppler, ये blood flow बस यही ऊपर तक ही है, but इसके चारों तरफ और इसके अंदर कोई blood flow नहीं है. But in malignant, just see the blood flow internally. The blood vessels are there. Okay, so it is the job of a radiologist usually who will do and who will classify that adnexal mass or ovarian mass depending upon these features as benign or malignant. But at least as a clinician, we should also be aware that these findings are will guide us that whether the woman is suffering from a benign or a malignant ovarian mass. ये हमें भी पता होना चाहिए. Okay, so those were the features of the adnexal mass on ultrasound. But what are the additional ultrasound features which will make me suspect that this particular woman is having malignant neoplasm? If there is ascites, presence of omental caking का मतलब होता है the omentum has become thick. It has become thick and it is visible that there is clumping or thickness of the omentum, जिसको कि we call it omental caking. Presence of enlarged nodes on ultrasound or by CT scan. And sometimes matted bowel may be fine, but again it is difficult to detect by ultrasound. So if ultrasound, but once ultrasound is done, the patient is diagnosed that she is suffering from ovarian neoplasm. She has to undergo again maybe a CT whole abdomen pelvis depending upon that what has to be the plan of surgery. सिर्फ अल्ट्रासाउंड से ही काम नहीं चलेगा. So it is a basic investigation which is available at every place. For CT scan to report a CT scan, a specialist will be required. तो अगर हमें पता चल गया on ultrasound that there is a mass, the next is the tumor marker testing that we advise, and this is a battery of say tumor markers that we have. We have cancer antigen CA125 को cancer antigen 125 है, cancer antigen 19.9, alpha fetoprotein carcinoembryonic antigen, beta HCG, LDH, serum inhibin. But not all the markers are done in all the patients. Okay, so like serum cancer antigen CA125, it is a very non-specific marker. It is not only raised in malignant, it is also raised in tuberculosis, it is also raised in benign conditions like endometriosis. Okay, so a raised CA125 will not label the woman as suffering from ovarian cancer. It is a very non-specific tumor marker. Cancer antigen 19.9, carcinoembryonic antigen, usually they point, if they are raised, usually they point towards that the carcinoma is originating from the GI tract. The primary more or less is in the GI tract. But ये suspicion मुझे कब होगा? जब मुझे clinical examination में bilateral ovarian masses मिलेंगी. On ultrasound, I will get bilateral ovarian masses because a primary ovarian cancer usually mostly is unilateral and a metastatic or secondary ovarian tumors are mostly bilateral. है ना? So all those primary tumors which are originating in the gastrointestinal tract, जिसका primary GI tract में है, GB cancer, stomach cancer और colon cancer, when they metastasize to the ovary, जिसको we call it Krukenberg tumors, usually they are bilateral. So on ultrasound, I will get a bilateral tumor. On PV examination, I will get bilateral enlarged ovaries. And on say examination on tumor markers, when I will get this CA 19.9 and CEA done, they will be raised much more than CA 125. Okay, so these tumor markers will help me in differentiating more or less towards whether it's a primary ovarian or it's a secondary ovarian tumor. And then beta HCG is there. Beta HCG is more or less, it is more important in gestational trophoblastic neoplasias. And alpha fetoprotein, LDH or serum inhibin, they are also raised in those tumors which are observed in a younger age. Like LDH is raised in dysgerminoma. Okay, so depending upon the age of the patient, dysgerminoma usually presents in younger population. Epithelial cell cancers जो होते हैं, they usually present in 30s, 40s or 50s. and in that particular woman, the CA125 will be more appropriate as compared to LDH. Now, CA125 is the commonest tumor marker which is evaluated in a suspected ovarian neoplasm. मैंने neoplasm लिखा है. Neoplasm means benign or malignant. It is not synonymous with malignancy. Okay, so it is benign or malignant. It is a non-specific marker. It is elevated in gynecological and non-gynecological conditions, and it may be elevated in both benign and malignant gynae conditions, and the cutoff is different for both pre and the post-menopausal patient. Pre-menopausal के लिए cutoff values क्या हैं? More than 200 units per ml. But again, the woman that premenopausal woman needs to be evaluated to confirm or to refute ovarian neoplasm. And so many of the times we get referrals that the woman is having a slightly enlarged ovary and the CA125 is 70 or 60. And the patient is worried that she is having ovarian cancer. But again, for a premenopausal, the value is up to 200. So more than 200 hai, then if the value is, we take 200 units per ml, it will detect 70 to 79% of premenopausal women with ovarian cancer. और अगर यही वैल्यू मैं postmenopausal में यूज कर रही हूँ, it will detect about say 94-95% of the women with ovarian cancer. And in postmenopausal, we take a cutoff of 35. So we should remember that in postmenopausal women, the values of the CA125 which has to be taken as cutoff is 35. ये वैल्यू नंबर याद होना चाहिए. और प्रीमेनोपॉजल के लिए 200 है. Usually, like a woman with endometriosis will have a raised CA125. But again, endometriosis or endometriotic chocolate cysts, sometimes they also convert into endometriotic carcinoma. And so, yeah, so ovarian carcinoma, those chocolate cysts, sometimes they may convert into endometriotic carcinoma. So, a premenopausal woman, if she has एक single value से कुछ नहीं होगा. If she has a persistently rising value, like her previous value was 60 raised, or 70, or 80, then 200, then 400, then 800, a rising trend will prompt me to evaluate the patient, because in a benign condition the value will not rise more than 200, and a single value will not make me judge whether she is suffering from a malignant or a benign neoplasm, especially in premenopausal.
Younger age group में भी chocolate cyst.
हाँ बिल्कुल. It can be there at about 24, 26 or 30 years. Because you will get a finding of a adnexal mass, a tenderness will be there. She will not be able to conceive.
Hemorrhagic ovarian cyst भी करके आते हैं. Hemorrhagic ovarian cyst.
But again, a hemorrhagic ovarian cyst, you will not advise her CA125. It is not required, because there is a hemorrhage in the ovary. The values might be raised. So there is no point in getting CA125 done in a hemorrhagic cyst. See, in each and every menstrual cycle, a corpus luteum formation is there. हर cycle में होता है, and there may be a chance that hemorrhage has happened in the ovary. The simple thing is that I have to follow the patient after 8 weeks. 8 weeks के बाद अगर repeat में examination और ultrasound करेगी, वो advice करेंगे, the findings will be absolutely normal. So a hemorrhagic ovarian cyst, though the patient will experience a dull aching pain, she may experience menstrual cycle abnormalities for 2-3 months, but it will resolve by itself. But provided it is a hemorrhagic ovarian cyst, it has to be a clear diagnosis. Okay, so, and in that particular patient, we need not advise CA125, because once it is raised, the patient is counseled that there is a cancer in the ovary. Okay, so a single value will not label the patient as suffering from malignant neoplasm. But again, in a young patient, if the values are rising, I have to reevaluate her, because ovarian cancer can happen. At least a week, say at least a month, not less than that. किसी भी, क्योंकि आप उसको ऐसे छोड़ भी तो नहीं सकते कि 6 महीने में आना. You have to decide whether she needs to be operated upon or not. So at least a month. So you will do a clinical examination, you will do a CA-125. So there are many girls who come with a CA-125 of 200 or more than that, and there is a finding on clinical examination or on ultrasound. But what we will do, we will reevaluate her after we ask her, say we will give her some hormone preparations, we will give her some painkillers, we will reevaluate her after 15 days or after 1 month, and we will repeat it. If there is an increasing trend of CA-125, it is always better to open and see the patient than to leave the patient, okay? Because findings भी है, symptoms भी है, tumor markers भी raised है, then I have to offer her surgery. Age is no bar. Age is no bar. We get young girls, 18, 16, 14 years. We get early age women, just married, 22, 23. We get 50, we get 60, we get 70. Each and every age woman is there in our hospital. Girls are also there, and a postmenopausal woman is also there. So if the woman is having symptoms and on examination there is a finding, I have to keep her under observation. ज़्यादा चांस malignancy का old age में होता है, but for ovarian no age is immune. Dysgerminoma is very common in young women. Dysgerminoma, then teratoma, though it is benign one. Teratoma, sex cord cell tumors. We get all type of tumors. So it is very common. So if there is a adnexal mass, that too solid, and on ultrasound the features are suggestive of solid ovarian mass with say malignant like features, I have to offer her treatment or referral, whatever it is. CA-19.9 कर सकते हैं, but usually CA-19.9 is present in those ovarian neoplasms where the primary malignancy lies in the GI tract, in the say in the sigmoid or in the large bowel, small bowel. It can be done. It has to be done. Usually many of the times one of the say and this primary malignancy in the GI tract usually will manifest as a bilateral ovarian tumor. Unilateral usually is not a metastatic ovarian tumor. Usually, but again, to have a basic idea about the tumor markers, it can be offered to a patient. But ये findings will be in most of the times these values will be normal. But ये denote करता है कि the GI malignancy is there. So for ovarian CA-125 inhibin है, then LDH है ना, अल्फा फीटोप्रोटीन है जो जर्म सेल और योग सेल सब सारी ट्यूमर्स है. सो डिपेंडिंग अपॉन द एज, बिकॉज ओवेरियन ट्यूमर्स का जो प्रेजेंटेशन होता है हिस्टोलॉजिकल, दे वेरी अकॉर्डिंग टू द एज. So again, by getting this CA-125, sometimes we are in dilemma whether she is having cancer or not, whether we want to operate her or not. Then we have certain tools, and one of the tool is risk malignancy index. Risk malignancy index, and it is an index that helps to predict the probability of malignancy in a particular patient. And age, menopausal status, and ultrasound findings are combined to provide RMI in a woman. A RMI score of 200 अगर लेंगे, then it has a sensitivity of 78% and a specificity of 87%. A RMI score cutoff of 50 has a sensitivity of 91 and it has a 74% of specificity. There are two systems, RMI1 and RMI2. So a RMI1 score of more than 250, like cutoff ही 200 ले रहे, 200 ही है, not 250. Of 200 should be referred to a gynae oncologist. अब ये क्या है RMI स्कोर, अल्ट्रासाउंड में क्या स्कोर है, मेनोपॉजल स्टेटस क्या है, और पेशेंट का CA-125 लेवल है. ये एक सिंपल टूल है जिससे हम लोग को एक OPD में आइडिया हो जाता है कि ये बेनाइन है कि मलिग्नेंट है. ये तो क्या क्या है, दो अल्ट्रासाउंड फीचर्स दैट वी टेक यूनिलॉक्युलर है कि मल्टीलॉक्युलर है, उसमें सॉलिड एरियाज whether it's bilateral or unilateral, ascites and presence of intra-abdominal metastasis. इसमें अगर none कोई भी फीचर नहीं है, हालांकि कोई ना कोई फीचर जरूर होगा, so that will be taken as 1. So 1 abnormality and 3 लेते हैं if it has 2 or more abnormalities. और प्री-menopausal status is given one number and post-menopausal status is given 3 और अगर RMI score 2 है तो उसमें 4 लेते हैं और इसको मल्टीप्लाई कर लेते हैं. सिंपल इज टू डू मल्टीप्लिकेशन. सो किसी पेशेंट का प्री-menopausal है 1 और उसका है CA 125 मान लीजिए 70 आ गया है, रेज्ड है, हालांकि द वैल्यू शुड बी मोर देन 200 है ना. 70 है, so 70 and 1 is 70 and she has one feature unilocular cyst, तो 70 होगा. So that score is RMI is less than 200. So the clinical possibility is that she is suffering from a benign neoplasm. So an important tool which guides us after getting a clinical examination, after getting an ultrasound and CA 125 to put the patient into a benign है कि malignant है. RMI score of more than 200 puts a woman at a risk of malignancy. Malignant है. So referral to a gynae oncologist. Pre-menopausal का क्या है? If the value is very much raised, more than 200, है ना? So referral is required whether she needs a follow-up or not. Presence of ascites in a pre-menopausal woman and evidence of abdominal or distant metastasis. And for post-menopausal, refer if any of these are present, a value of elevated, say the CA 125 is elevated, ascites, nodular or a fixed pelvic mass, evidence of abdominal or distant metastasis. So if there is a doubt, she has to be referred to a gynae oncologist. So what to conclude? Ideally, a clinician should have a high suspicion of ovarian neoplasm in a woman or in a girl who is presenting with abdominal symptom or GI symptom or symptoms like weight loss and urinary symptoms. Second thing, we should focus on early symptom recognition. कुछ नहीं है, ऐसे ही होता है. It should not be like that. I have to examine her. I have to examine her if the symptoms are persistent throughout the month, more than 12 times a month. If she is complaining of, I have to investigate her. Thorough history taking is very important. Then do a detailed clinical examination, a gynecological examination. For unmarried ones, we can't do a PS and a PV examination. But if I am getting a mass on the abdomen examination, I have to do a per-rectal examination, which we can do. And for married ones, there is no way that I am not doing a PS and a PV examination. It is must in all those patients who are married ones. And if there is a clinical finding, I will do imaging studies and I will do tumor markers to confirm my diagnosis. And then once the patient is diagnosed to be suffering from a malignant or a benign ovarian neoplasm, the treatment is required. Because if I am not the person who will do surgery, अगर मुझे नहीं करना है तो at least जिनको करना है उनके पास तो timely referral करें. I should tell the patient that go to this place to get yourself operated because the treatment of yours is surgery. Okay, so timely diagnosis and timely referral will help our patients in getting appropriate treatment, because with, as I said, that with early stage ovarian cancers, it is potentially curable. We have many patients on follow-up who are living for more than 5 years, 3 years, 4 years, 5 years, and they do come for follow-up. If we counsel them accordingly that you have to come at each and every month, she comes, and there is a disease-free interval of more than 3, 4 or 5 years. So, counseling karna is very important about the treatment that she requires, and when the treatment is done, many of the patients they are lost to follow-up. उनको लगता है कि ऑपरेशन हो गया तो कैंसर सब ठीक हो गया, but again this is a disease which will need a long-term follow-up. Okay, so I think that is the last slide. So thank you very much.
How many of you have ever encountered GPN? Mostly benign. Benign में what you get commonly? Vesicular mole. So how many of you have encountered vesicular mole?
Yes.
So how did you diagnose? मतलब based on sign symptom, based on ultrasound.
Ultrasound.
Like it was an incidental finding. or
DNC
you were suspecting?
I was suspecting because she was excessively vomiting and means it was out of means she was not able to digest anything. So I thought there is something wrong with the pregnancy, and then I saw in my ultrasound I found some mole tighter structure. Then I sent it to my medical college in Jhansi. Then she got diagnosed there.
So you suspected based on the sign and symptom. You know that what she's saying is that the patient presented with excessive vomiting. You know? So differential diagnosis you have to keep in mind. Excessive vomiting can be hyperemesis gravidarum also.
Gravidarum also.
You know? So
It can be twin
specifically based on excessive vomiting you cannot diagnose. You have to correlate with other sign and symptom because excessive vomiting is a non-specific symptom. You know? So
usually, ma'am, after the DNC, the patient again come with the bleeding, and after the re-DNC again, third time she is coming, then we are going to suspect. Okay, we have to go for beta HCG.
because I tell you, you might not see much of ovarian cancer in your clinical practice. आप ovarian cancer इतने नहीं देखेंगे, है ना? बहुत ज़्यादा कि बड़े मार्स और ट्यूमर, बट GTN आपको आना चाहिए क्योंकि GTN आपको फ्रैंक नहीं मिलेगा, हिडन मिलेगा. एंड आपका बेसिकली द पर्पज इज यू कैच इट. आप उसको वहां पकड़ लें दैट अर्ली स्टेज एंड यू रेफर इट टाइमली. बिकॉज बहुत बार ना आप मोलर तो यू कैन डायग्नोज कि अल्ट्रासाउंड लेके आ रहा है. बहुत बार जो एक GTN है जो मेलिग्नेंट फॉर्म है उसको इट मैस्कुरेट्स, वो इट लाइज इन द हिडन फॉर्म. वी विल डिस्कस इट. ठीक है. सो व्हाट इज GTN? What GTN is different, है ना? There are two terms. One is GTD and one is GTN. ठीक है? तो basically we are talking about gestational trophoblastic disease. है ना? Disease is a broader term. उसके अंदर आपको GTN आएगा. GTN is malignant और benign, है ना? So what is GTD? GTD is a term used to describe the heterogeneous group of interrelated lesions that arise from abnormal proliferation of placental trophoblast. Normally जो placenta में trophoblast है, pregnancy हुई, placenta is out, it is out, है ना? But many a times these placental trophoblasts, when they proliferate abnormally, it leads to entity called as gestational trophoblastic disease. Or what is GTN? GTN, it includes malignant disease related to gestational trophoblast. क्या कर सकते हैं? Treatment of molar is by suction evacuation, and 80% में it gets cured. आपका अगर you have done a good suction evacuation, है ना? If facility are there under ultrasonic guidance, if facility are there, so 80% में it will be complete. Procedure will be complete. But in some cases, it is seen that in 15 to 20% cases, है ना, it can lead to development of GTN later on. कि आपके कुछ टिश्यूज रह गए या कुछ ट्रोफोब्लास्ट है that have been not evacuated, that will proliferate and will lead to formation of GTN later on. So although GTN commonly follows molar pregnancy, मगर जरूरी नहीं है कि GTN आपको मोलर के बाद हो. नॉर्मल डिलीवरी के बाद भी GTN हो सकता है. एक नॉर्मल स्पॉन्टेनियस अबॉर्शन हुआ है उसके बाद भी GTN हो सकता है. एक मिस्ड अबॉर्शन है, इनकम्प्लीट अबॉर्शन है, उसके बाद भी GTN हो सकता है. मतलब जब भी आपकी बॉडी में कोई ट्रोफोब्लास्ट टिश्यू आया, later on it can lead to GTN. Like we get many patients who come with history of whom we diagnose as GTN और उसमें कोई मोलर नहीं था, कोई उसका अबॉर्शन नहीं था, कुछ नहीं था. When we take the history पता चलता है 3 years back she had a vaginal delivery, 2 years back she had a vaginal delivery. Now how did we diagnose GTN? Now she has come with irregular bleeding, on and off bleeding, all those things. ठीक है? So this is important कि GTN से मोलर से ही नहीं होगा, आपका स्पॉन्टेनियस अबॉर्शन से भी हो सकता है, एक्टोपिक प्रेगनेंसी से भी हो सकता है, टर्म प्रेगनेंसी से भी हो सकता है. जब जहां पे भी आपकी बॉडी में कोई भी ट्रोफोब्लास्टिक टिश्यू आया है एट एनी टाइम, इट कैन डेवलप GTN later on. Now you must be familiar with this classification of GTD. This is GTD. उसमें there are two entities, benign and malignant. Benign में we have complete mole and partial mole. And malignant में what we have? Common is post-molar GTN. That is commonest. Other is choriocarcinoma. Another entity is invasive mole. Another is placental site trophoblastic tumor. Although not very common, but we get to see. At our tertiary care, we happen to see few cases in 4-5 years. So, placental site trophoblastic tumor and epithelioid trophoblastic tumor. So, these are the classification of malignant. Benign तो हमें सबको पता है. Now, first we will discuss benign and then we will proceed towards malignant. So, benign में most of you must be familiar. H mole. अगर आप patient कैसे आएगी? How will the patient present? What sign and symptom the patient will present? And when will you suspect that she might be a molar pregnancy? Important is the patient will present with symptom of, she will give a history of amenorrhea, है ना? And there might be history of some bleeding or pain abdominal in 70% of the cases. But passage of vesicle is not observed always. आपको grape-like vesicle हमेशा नहीं मिलेंगे. जब patient is in abortion phase, when she is aborting, then only you will get to see the grape-like vesicles. Normally आपको grape-like vesicles नहीं मिलेंगे. And as she said, hyperemesis is seen in 30% of the cases. Why hyperemesis?
Because of
increase in beta HCG level. है ना? Because trophoblastic tissue बहुत सारा है और beta HCG trophoblastic tissue से आता है. So there is abnormal proliferation of trophoblastic tissue that leads to increased production of serum beta HCG. So hyperemesis, and also if you get to see hypertension, है ना, before 24 weeks, then also you suspect. अगर previously उसको chronic hypertensive नहीं थी patient, previously उसका prior to pregnancy BP normal रहता था, मगर अब बहुत early after 20 weeks को भी label it as gestational hypertension. But अगर before 20 weeks आपको blood pressure बढ़ा हुआ मिल रहा है, तो पहले उसका normal आता था, then you should suspect, है ना? Then thyrotoxicosis. Patient might be presenting with signs and symptom of thyrotoxicosis. Because जो beta HCG है, it mimics thyroid hormone, TSH. They mimic together. That is why. So, thyrotoxicosis, sign and symptom, patient might present with palpitation, with tachycardia, with supraventricular tachycardia, because both TSH and HCG share a similar structure. And 1% women might be asymptomatic. And you might incidentally diagnose on ultrasound, or if you find that uterus is bigger than period of gestation. Like suppose she is 10 weeks pregnant, and when she is coming, you find uterus is 20 week size, uterus is 16 week size, it is undue and large, then you should suspect it might be a molar pregnancy. Okay. So these are the common signs and symptoms. Then all of you must be aware, है ना, classical हमें ultrasound में क्या मिलता है? We don't see any fetus. कुछ fetus होता ही नहीं, ना कोई placenta दिखता है. We see snowstorm appearance. ऐसे snowstorm appearance मिलती है. Why it is snowstorm appearance? Because जो trophoblastic tissue है, they get filled with fluid-like vesicles. है ना? Grape, इसी को कहते हैं grape-like vesicles. Because the trophoblastic, there is hydropic degeneration. In books, the term is mentioned, there is hydropic degeneration of trophoblastic villi that leads to formation of grape-like vesicles. Now, symptoms अलग है, sign अलग है. जो हमने symptoms we discovered, amenorrhea, pain, might be there, bleeding, then palpitation, hyperemesis, then blood pressure. These are the symptoms. Then signs में symptoms patient will tell. Signs में what clinician will see, है ना, that is sign. तो आपको sign में क्या मिलेगा? When you will examine, when you will do either the PA or PV examination, you will feel that uterus is doughy in consistency. Doughy. It is soft. It is doughy in consistency. Why doughy? Because fetus है नहीं अंदर और amniotic fluid भी नहीं है. नॉर्मली क्या होता है, एमनियोटिक फ्लूइड होता है अंदर, फीटस होता है, तो यूट्रस फील्स फर्म कंसिस्टेंसी, तो आपको बिल्कुल बॉगी से सॉफ्ट सा यूट्रस मिलेगा. तो यूट्रस फील डोई इन कंसिस्टेंसी बिकॉज देयर इज नो एमनियोटिक फ्लूइड. एमनियोटिक फ्लूइड होगा तो वो टर्जिड हो जाता है, तो उसको स्ट्रेच करता है यूट्रस को. So uterus will be doughy in consistency. And another is you will not feel any ballotment, external or internal ballotment. है ना? All of you must be knowing ballotment. Ballotment कैसा होता है, जब फीटस है और खूब सारा फ्लूइड, एमनियोटिक फ्लूइड है, अगर आप पीए करेंगे, इधर से पुश करेंगे तो फीटस इधर रन करेगा, इधर से पुश करेंगे इधर रन करेगा. और पीवी में भी यू विल फील बलॉटेबल, क्योंकि जब फ्लूइड ही नहीं है तो फीटस ही नहीं है, तो कोई बलॉटेबिलिटी यू विल नॉट फील. सो आपको यूट्रस डोई मिलेगा, यूट्रस एनलार्ज मिलेगा मोर देन पीरियड ऑफ जेस्टेशन, एंड यू विल नॉट गेट टू एलिसिट एक्सटर्नल ballotment or internal ballotment. Or another finding might be there is you might find when you will do PV examination some masses through the fornix. आपको कुछ ovarian masses टाइप के मिल सकते हैं. That might be because of theca luteal cyst. ठीक है, because they occur quite often. Molar pregnancy के साथ theca luteal cyst they occur quite often because of increase in beta hCG. So theca luteal cyst मिल सकता है, या अल्ट्रासाउंड में आपको मिल सकता है. मोलर के साथ कुछ ओवेरियन सिस्ट है, ठीक है. सो मोस्टली दे आर theca luteal cyst. Now as we discussed that 80% of molar pregnancy resolved by treatment. जो आपने सक्शन किया, if you have done correctly, है ना, तो अगर आपने कंप्लीट इवैक्यूएशन किया है तो इट विल रिजॉल्व, 80% विल रिजॉल्व बाय ट्रीटमेंट. बट 15 to 20% may develop post molar GTN. Molar pregnancy के 15 to 20% cases they can develop GTN, and 5% can land up in choriocarcinoma. That is why molar pregnancy को we keep for follow up. Your job is not done. आपके पास मोलर आया, आपने सेक्शन कर दिया, खत्म. It is incomplete treatment. You have to keep that patient for follow up for how long? 1 year. 1 year. हाँ, 1 year. आपको follow up में रखना है patient. Beta hCG monitoring, है ना, क्योंकि you never know कि उसका कब molar can change into GTN. So that is very important. You keep patient for follow up for 1 year by beta hCG monitoring. That is very important. Now, molar pregnancy का what other differential diagnosis you can have? Because ultrasound में भी many a times picture you might not get classical storm appearance. ठीक है? So उसके अलावा और differential diagnosis क्या है? Partial mole है ना, molar के DD क्या है? Partial mole है या early non-molar gestation with florid trophoblastic hyperplasia. ये early fetus है, उसका प्लेसेंटा बहुत बिग है, या उसमें बहुत सारे विलाई और ट्रोफोब्लास्टिक प्रोलिफरेशन है ना. सो दैट माइट मिमिक, वो भी कभी कभी आपको पिक्चर ऐसी लग सकती है कि मोलर है मगर वो मोलर नहीं है. उसको कंफर्मेशन कैसे करेंगे? हिस्टोपैथ. जब आपका जो भी प्रोडक्ट निकलेगा, एक तो ये डिक्टम है कि यू शुड ऑलवेज सेंड product of conception for histopath in cases of incomplete abortion, missed abortion और molar और partial molar. हिस्टोपैथ में जरूर भेजिए, क्योंकि हो सकता है जिसको आप मिस्ड अबॉर्शन समझ रहे हो वो आपका पार्शियल मोल है ना. मोलर तो समझ आ जाता है कि वेसिकल दिखेगी, ये दिखेगा, मगर पार्शियल मोल, इनकम्प्लीट अबॉर्शन, मिस्ड अबॉर्शन, उसमें डिफरेंशिएट करना मुश्किल होता है. अगर आप हिस्टोपैथ नहीं भेजेंगे, सिर्फ अपने सक्शन करके यू लीव द पेशेंट, एंड सपोज वो मिस्ड अबॉर्शन नहीं था, वो पार्शियल मोल था, तो लेटर पेशेंट विल डेवलप इनटू GTN. अगर आपको पता चल जाएगा कि पार्शियल मोल आया तो आप उसको फॉलो अप में रखेंगे, तो चांसेस ऑफ GTN तो बनेगा ही, बनना होगा बॉडी में, मगर यू विल पिक इट अर्ली. फॉलो अप में रखने से फायदा क्या है कि आप उसको अर्ली पिक कर लेंगे. आप पैथोलॉजी तो नहीं, यू कैन स्टॉप बॉडी, उसको बनना है तो GTN बनेगा ही, मगर यू विल कैच दैट पेशेंट अर्ली एंड टाइमली ट्रीटमेंट. नहीं तो क्या होगा, इट विल लीड टू हायर स्टेज डिजीज अगर हम उसे फॉलो अप में नहीं रखेंगे. So that is important. So if facilities are available, always send product of conception for histopath examination in abortion cases or in molar. or partial mole. That is very important because हमारे पास जो cases आते हैं maximum we get referred patient of GTN. उसमें क्या होता है, there is history of some abortion, abortifacient intake or whatever, and then 6 months back, 1 year back, and then when they come to us, few patients come to us even in choriocarcinoma, advanced stage, or even in early stage, but they are a bit more advanced because of the lack of follow-up. So complete mole, ये तो क्लासिकल पिक्चर होती है, कोई फिटस नहीं होता, स्नोस्टॉर्म अपीयरेंस होता है. मगर पार्शियल मोल इज डिफरेंट. पार्शियल मोल में क्या है, दैट इज व्हाई इट कैन बी कंफ्यूज्ड विद अ नॉर्मल प्रेगनेंसी, बिकॉज पार्शियल मोल में आपको फीटस दिखेगा एंड प्लेसेंटा भी होगा, मगर दैट फीटस विल बी स्मॉल डिफॉर्म्ड फीटस एंड प्लेसेंटा विल बी बिग हाइपरप्लास्टिक और थोड़े वेसिकल्स होंगे. तो आपको अल्ट्रासाउंड में हो सकता है नॉर्मल प्रेगनेंसी जैसा दिखे, दैट अल्ट्रासोनोलॉजिस्ट इज नॉट वेरी एक्सपर्टाइज इन दैट. ठीक है. सो पार्शियल मोल ऑफन प्रेजेंट विद oligohydramnios, intrauterine growth retardation or malformed fetus as detected on ultrasound. During second trimester, few vesicles may be seen on placenta. Malignant potential of H mole is 15 to 20%, but partial mole में malignant potential is less, around 0 to 5%. तो इसीलिए product of conception देखना is important because to diagnose partial mole, क्योंकि लगेगा हमें नॉर्मल प्रेगनेंसी और हमने सक्शन करके छोड़ दिया तो 5% तो still 5% is quite a high number. They can land up into GTN. So complication, as we discussed, all of you told the hyperemesis, pregnancy-induced hypertension. Then another complication is thyroid storm because of the raised SCG thyroid. Then patient can bleed profusely. Molar pregnancy, all of you must, those who have encountered or seen the cases, they bleed profusely. So that patient can land up into hemorrhage, shock. And another complication that can occur is embolization. Embolization is mostly it occurs when you are doing suction evacuation. जब आप suction evacuation करते हैं and at that time the vesicles जो होते हैं they can embolize through the uterine artery into the systemic circulation. So and that can lead to acute pulmonary insufficiency or even DIC. So all these things we should be keeping in our head when we are dealing with molar pregnancy. It is not just simple suction evacuation. So preferably if facilities are there, we should do under
one kind of duty to be there.
When you suppose a molar pregnancy has come to you, basically तो you will refer to us. अगर आपके पास डायग्नोज केस आ गया अल्ट्रासाउंड में मोलर है तो आपको उसको रेफर ही कर देंगे पहले. मगर सपोज आपको लग रहा था कि इनकम्प्लीट अबॉर्शन है या कोई पेशेंट ब्लीड करती हुई आ गई तो आपको लगेगा इनकम्प्लीट अबॉर्शन है, लेट्स डू द सक्शन, और सक्शन के टाइम आपको लग रहा है वेसिकल्स आ रहे हैं, ये सब आ रहे हैं, तो देन यू हैव टू बी विजिलेंट कि ये मोलर हो सकता है. तो उसमें क्या क्या प्रिकॉशंस लेंगे ऐसे केसेस में. एक तो प्रिफरेबली डू अंडर ओटी सेटिंग वेयर द फैसिलिटी फॉर जीए इज देयर. सपोज पेशेंट लैंड्स अप इन पल्मोनरी इनसफिशिएंसी, ब्रेथलेस हो जाए पेशेंट, तो एटलीस्ट यू हैव अ बैकअप फॉर जीए. एंड you should do rapid evacuation. Molar pregnancy में आपको rapid suction evacuation करना है. That with a wide bore cannula, मोटे कैनुला से. जैसे नॉर्मल में हम क्या करते हैं 6 या 8 नंबर पतले कैनुला से सक्शन करते हैं, मगर मोलर में ट्राई टू यूज अ वाइड कैनुला ताकि यू डू सक्शन इवैक्यूएशन फास्ट. जल्दी से फास्ट इवैक्यूएशन करेंगे, जल्दी से प्रोडक्ट निकल जाएंगे, यूट्रस विल कॉन्ट्रैक्ट फास्ट, ब्लीडिंग विल बी लेस. ठीक है. सो मोलर प्रेगनेंसी में ट्राई टू यूज वाइड बोर कैनुला फॉर सक्शन इवैक्यूएशन and try to do it fast and put on the syntocinon drip 20 units ताकि uterus contract fast. ठीक है. So all these things you should keep in mind molar pregnancy. And if facilities are there, if patient is pouring or heavily bleeding, you should arrange blood. All these things you should keep in mind. Or another is we should get a pre-beta HCG, pre-evacuation beta HCG, baseline beta HCG. आप लोग तो बेसिकली रेफर ही कर देंगे, मगर फिर भी जस्ट फॉर योर नॉलेज कि एक बेसलाइन बीटा एचसीजी मोलर प्रेगनेंसी डायग्नोज हुई, सबसे पहले बीटा एचसीजी करा लीजिए, बिकॉज उसी से आप कंपेयर करेंगे कि वैल्यूज फॉल कर रही हैं, राइज कर रही हैं या प्लेटू कर रही है ना. सो बेसलाइन बीटा एचसीजी इज इम्पॉर्टेंट. हर पेशेंट में यू गेट अ बेसलाइन बीटा एचसीजी. सो और कॉम्प्लिकेशन क्या है, बिकॉज मोलर में यूट्रस इज वेरी सॉफ्ट, सो चांसेस ऑफ परफोरेशन आर मोर व्हेन यू आर डूइंग सक्शन इवैक्यूएशन इफ यू आर नॉट केयरफुल. और डिलेड कॉम्प्लिकेशन में इट कैन लीड टू रेकरेंट मोल हो सकता है, इन्वेजिव मोल, रेकरेंट मोल या कोरियोकार्सिनोमा बन सकता है. रेकरेंट मोल मतलब एक बार उसको मोलर हुआ है तो देयर आर हाई चांसेस, देयर आर चांसेस इन आई थिंक फ्यू परसेंटेज 8 to 10% में शी कैन अगेन हैव मोलर प्रेगनेंसी. ठीक है, दैट इज रेकरेंट मोल, फिर दोबारा मोल हो सकता है, और बाकी तो फिर उसको GTN हो ही सकता है. सो दीज आर द कॉम्प्लिकेशंस. सो डायग्नोस्टिक मोडालिटी में वी नो अल्ट्रासाउंड, बीटा HCG में इफ इट इज सपोज इफ इट इज मोर देन पीरियड ऑफ जेस्टेशन, जो वैल्यू आपकी आनी चाहिए उससे ज्यादा है, तो भी आपको सस्पिशन होना चाहिए. और मोलर जरूरी नहीं है मोलर आपका वही हो, यूट्राइन भी हो. वी हैव सीन ओवेरियन में भी हो सकता है, ओवेरियन एक्टोपिक. We had done ovarian ectopic, and when we sent it for a histopath, it turned out to be molar. So treatment is blood should be transfused, oxytocin drip, suction evacuation with white cannula, as it reduces the blood loss. And very important is always अगर आपके पास फैसिलिटी नहीं है तो उसको बाहर भेज दीजिए. ठीक है, दैट इज वेरी इंपॉर्टेंट. नाउ फॉलो अप इज वेरी इंपॉर्टेंट. मोलर प्रेगनेंसी का फॉलो अप आपको जरूर पता होना चाहिए कि नॉर्मली क्या होता है, बीटा HCG इट कम्स टू नॉर्मल विद इन 6 to 8 वीक्स आफ्टर इवैक्यूएशन ऑफ मोलर प्रेगनेंसी. आपने मोलर में क्या होता है, लैक्स में होता है जनरली ना, थाउजेंड्स में और लैक्स में होगा आपको बीटा HCG, बट इट्स वेरी थाउजेंड्स में होता है. और तो आपका नॉर्मली मोलर आफ्टर इवैक्यूएशन immediately it will not come normal. It will take 6 to 8 weeks for values to fall down. So that is why हम लोग पेशेंट का कैसे फॉलो अप करते हैं, वीकली बीटा HCG till it becomes negative. हम हर वीक कराते रहते हैं. हम पेशेंट को डिस्चार्ज कर देते हैं आफ्टर 48 hours. Then we call every week. We come with fresh beta HCG. Every week we chart the beta HCG and we see whether it is falling by 15 log. 15 log का fall है या नहीं. It should fall by 15 log. है ना? So every week we call and if it is falling, the trend is falling, then till it becomes negative, patient will come. Then जब negative आने के बाद, जब तक 3 negative नहीं आएगा, after negative, then we will call, again do 2 more till they are negative. उसके बाद क्या करेंगे, monthly. We call monthly for follow up for 6 months. So weekly beta HCG till negative. Once test become negative, अगर आप 2 और नहीं कराना चाहते हैं तो कोई बात नहीं, then आप monthly बुला लीजिए उसको for 6 months. Important is you should advise contraception and tell not to become pregnant for 1 year. Because अगर pregnancy हो गई तो pregnancy से beta HCG बढ़ेगा, तो आपको लगेगा कि मोलर से बढ़ रहा है. It will confuse. So it is recommended patient should not become pregnant for 1 year. तो आप उसको कोई contraceptive दे दीजिए. That is very important. And you counsel the patient also. Patient follow up में नहीं आते, बहुत सारे patient है ना, तो उसको थोड़ा सा बोलना पड़ता है. अगर follow up में नहीं आएगा तो हो सकता है कैंसर बनने की उम्मीद है. थोड़ा सा ना उनको you have to prime their mind कि आपका ट्रीटमेंट पूरा नहीं हुआ है. That is very important. And contraception में you can give pills or barrier contraceptive, not IUCD, because IUCD can cause irregular bleeding. And POP भी avoid करते हैं because progesterone only pill and IUCD we avoid because they cause irregular bleeding, so we will get confused. Molar की वजह से all those things. So that was about benign. So you have any queries regarding benign, or you want to share your some experience for benign? So after benign is gestational trophoblastic neoplasia. What is GTN? It is a malignant component of GTD and requires close attention in terms of recognition and diagnosis. Because diagnose नहीं कर पाते हैं. कैसे diagnose नहीं कर पाते हैं? हमारे पास बहुत सारे cases आते हैं कि कोई patient incomplete abortion का था या missed abortion का था. उसने पेरीफेरी में जाके कहीं पे भी उसने DNE करा लिया, सक्शन करा लिया, MTP करा लिया. MTP कराने के बाद फिर उसको ब्लीडिंग नहीं रुकती है, फिर वो अगेन वहां जाता है डॉक्टर के पास, डॉक्टर फिर उसकी DNC कर देता है, फिर भी ब्लीडिंग नहीं रुकती है, फिर वो अगेन जाता है, वो फिर उसकी MTP वो सक्शन कर देता है. तो मल्टीपल टाइम उसका सक्शन करता रहता है और ब्लीडिंग रुक नहीं रही है ना, तो देन इट शुड रेज अ सस्पिशन कि देयर माइट बी सम अदर प्रॉब्लम, हो सकता है जीटीएन हो या कुछ हो। ऐसे में यू शुड गेट अ सीरम बीटा एचसीजी डन। मल्टीपल सक्शन इवैक्यूएशन और डीएनई is not an answer. GTN is commonly missed due to lack of knowledge by a physician treating abortion, ectopic or molar pregnancy. This is particularly with missed abortion. क्योंकि missed abortion का आपको पता नहीं है क्या है, कि हो सकता है partial mole हो, missed abortion. So very important. Any case of incomplete abortion or missed abortion that does not respond to one uterine evacuation should be thoroughly investigated to rule out GTN before going for repeated evacuation. अगर आपने repeated evacuation करने से पहले आप उसमें you should be alert, ठीक है, क्योंकि आपको तो लगा अच्छे से सक्शन कर दिया था, सब कर दिया था, मगर फिर क्यों पेशेंट ब्लीड कर रही हो ना, अल्ट्रासाउंड में भी आपको कोई नहीं दिख रहा है कि बहुत सारे प्रोडक्ट हैं या कुछ रिटेन रह गया, फिर आप वो कर देते हैं सक्शन। सो दैट इज वेरी इंपॉर्टेंट। दिस इज द टाइम यू रेफर द पेशेंट। इस टाइम पे यू रेफर द पेशेंट। अगर आपने एक या दो बार सक्शन कर लिया, डीएनई कर ली, स्टिल द पेशेंट इज ब्लीडिंग एंड नॉट रिस्पॉन्डिंग, यू शुड रेफर। सो दिस इज इंपॉर्टेंट। फीगो क्राइटेरिया फॉर डायग्नोसिस ऑफ पोस्ट मोलर जीटीएन। अब आपको कैसे पता चलेगा कि मोलर प्रेगनेंसी थी और वो जीटीएन में बन गया? व्हेन देयर इज प्लेटू, आप बीटा एचसीजी कर रहे हैं, उसका हर वीकली कर रहे हैं बीटा एचसीजी, और अगर देयर इज प्लेटू इन एचसीजी ओवर एट लास्ट 3 वीक्स, ठीक है, आपने हर वीक उसका किया, आपने वीक 1, वीक 2, वीक 3, वीक 4, उन तीनों में अगर आपका लेवल फॉल नहीं कर रहा है, बीटा एचसीजी प्लेटू कर रहा है, देन यू शुड सस्पेक्ट जीटीएन, ठीक है। और इफ देयर इज राइज ऑफ ग्रेटर देन 10% इन बीटा एचसीजी ओवर एट लीस्ट 2 वीक्स, दैट इज इन 3 कंसेक्यूटिव वैल्यू। आपके पास आज पेशेंट आई, आपने उसको अगले हफ्ते बुलाया, फिर आपने देखा बीटा एचसीजी रेज्ड आया है, एक रेज्ड वैल्यू पे यू विल नॉट डायग्नोज, यू कॉल इट अगेन आफ्टर 1 वीक, फिर आपने देखा फिर रेज्ड आया है मोर देन 10% विद जो आपका इनिशियल वैल्यू थी। तो इफ देयर इज राइज ऑफ ग्रेटर देन 10% इन बीटा एचसीजी ओवर एट लीस्ट 2 वीक्स, दैट इज 3 कंसेक्यूटिव वैल्यू, तो देन अगर आपकी वैल्यू प्लेटू हो रही है बीटा एचसीजी की या राइज हो रही है, देन इट शुड रेज अ सस्पिशन दैट इट माइट बी जीटीएन। और या जो आपने अपना मोलर सक्शन किया था उसको आपने हिस्टोपैथ में भेजा और हिस्टोपैथ की रिपोर्ट आ गई, रिपोर्ट में आ गया कोरियोकार्सिनोमा, तो देन इट इज जीटीएन। सो इट इज इंपॉर्टेंट कि जीटीएन आपको लेबल करने के लिए इट इज नॉट अ हिस्टोलॉजिकल डायग्नोसिस, इट इज बेस्ड ऑन योर बीटा एचसीजी वैल्यू। अगर आपके पास हिस्टोलॉजी है तो ठीक है, नहीं है तब भी आप बीटा एचसीजी की वैल्यूज के बेसिस पे यू कैन लेबल इट एज जीटीएन। इसके में आपको कोई वो नहीं चाहिए, हिस्टोपैथोलॉजिकल प्रूफ नहीं चाहिए। अगर आपके पास है तो वेल एंड गुड, जैसे इसमें था कि आपने मोलर किया, उसमें कोरियोकार्सिनोमा आ गया, सो बेस्ड ऑन बीटा एचसीजी वैल्यू राइजिंग और प्लेटूइंग यू कैन लेबल इट एज जीटीएन। सो जीटीएन में बहुत सारी देयर आर कैटेगरीज। वन एज वी डिस्कस इन्वेजिव मोल कोरियोकार्सिनोमा। नाउ व्हाट इज इन्वेजिव मोल? Invasive mole, about 5 to 10% of GTN, they can be in form of invasive mole. Invasive mole, as the name suggests, there is a growth in the uterine cavity and it will burrow into the myometrium. It will burrow, erode through the myometrium, and it can cause dangerous hemorrhage, even intra-abdominal. Peritoneum में भी अगर वो growth perforate करके uterus के बाहर आ गई, if it perforates the uterus growth, the patient might not bleed vaginally, patient can bleed in the abdomen, and it can lead to even massive bleeding, that patient can go in shock, ठीक है। So invasive mole में if the growth can lead to dangerous internal hemorrhage, and जो invasive mole है they behave like locally malignant. Invasive mole is generally they don't spread, distant metastasis कम होती है invasive mole, they are mostly confined to the uterus or up to the pelvic cortex mostly. Like कोरियोकार्सिनोमा में तो आपकी बहुत fast metastasis होती है distant. So invasive mole they behave like a locally malignant lesions. Now कोरियोकार्सिनोमा. कोरियोकार्सिनोमा आप कैसे diagnose करेंगे? How will you diagnose कोरियोकार्सिनोमा?
High level of beta एचसीजी
कोरियोकार्सिनोमा तो सीक्वल है प्रेगनेंसी में नहीं होता, वो प्रेगनेंसी इज वेरी हाई। कोई पेशेंट है आपके पास इरेगुलर ब्लीडिंग करके आ रही है, इरेगुलर एब्नॉर्मल यूट्राइन ब्लीडिंग करके आ रही है, एंड एब्नॉर्मल यूट्राइन ब्लीडिंग में मेनी अ टाइम्स होता है कोई पेशेंट हमारे पास 45 ईयर है, 50 ईयर है, एब्नॉर्मल यूट्राइन ब्लीडिंग करके आ रही है, तो जनरली वी गेट अ ईबी ड्रग, एंडोमेट्रियल बायोप्सी ड्रग, उसमें आगे आ गया आपको। या मेनी अ टाइम्स इफ अ पेशेंट गिव्स हिस्ट्री कि 6 months back she had an abortion or normal delivery one year or 2 year back, and when we are thinking we suspect हो सकता है कोरियोकार्सिनोमा, and we get a beta HCG done, it will be abnormally high, abnormally elevated in lakhs views. How do you diagnose? With high beta HCG and histological examination shows all type of trophoblastic tissue but no chorionic tissue. So trophoblastic tumor following a full term pregnancy is always choriocarcinoma. Full term pregnancy हुई है उसको 2 year 3 year back, and now she has come with abnormal uterine bleeding. तो आपको कोई cause नहीं मिल रहा है ना? Then you should suspect कि आपने endometrial biopsy में आगे choriocarcinoma. And it is said that after normal pregnancy, अगर आपके पास GTN develop होगा तो it will always be choriocarcinoma. Like after abortion, after molar. It can be anything, invasive mole, PSCT, anything. But mostly, trophoblastic tumor following full-term pregnancy is always choriocarcinoma, whereas it may be either invasive mole or choriocarcinoma if it follows molar pregnancy or incomplete abortion. Irregular bleeding करके आ रही है कोई है तो preceding amenorrhea की हिस्ट्री है, आप पूछेंगे पहले amenorrhea तो नहीं था, उसकी पहले साइकिल्स रेगुलर आ रहे हैं 2 महीने, most unlikely, all those things. ये आपको क्लियर हो रहा है ना these things? So trophoblastic tumor diagnosed up to 6 months following an abortion or more is often invasive mole, but tumor diagnosed later than 6 months. So we had discussed invasive mole, we had discussed choriocarcinoma. Then another is placental site trophoblastic tumor. And a placental site trophoblastic tumor, they occur only in 1% of trophoblastic disease. And it arises from placental bed trophoblast. मतलब जहाँ पे आपका placenta implant हुआ होगा in pregnancy, when the patient was pregnant. At that site, that arises. वहाँ पे जो remnant जो chorionic tissue जो रह गया है, so that can proliferate and that can lead to formation of placental site trophoblastic tumor. So it follows a full-term delivery in 95% of the cases, although rare in 5%, it can occur after molar also. So normally जो PSTT है, placental site trophoblastic tumor, it occurs after normal pregnancy. And इसमें important feature of this is PSTT का क्या है? It is that HCG are lower than observed in choriocarcinoma and rarely exceed 2000 to 3000. बीटा एचसीजी आपको बहुत हाई नहीं मिलेगा, लैक्स में, थाउजेंड्स में, जैसे कोरियोकार्सिनोमा मिलता है, बिकॉज ये लोकल एरिया में है ना, लोकलाइज्ड है, सो इट विल बी लेस, बीटा एचसीजी लेवल विल बी लेस, इट विल बी अराउंड 3000 4000. एंड इन कंट्रास्ट टू ट्रोफोब्लास्टिक ट्यूमर, दे आर insensitive to chemotherapy. Like for most of the GTN, treatment is chemotherapy. What chemotherapy commonly we give? We give methotrexate, है ना? For low risk cases, and for high risk cases we give imaco, है ना? तो ये जो placental site trophoblastic tumor है, इसमें कीमो काम नहीं करेगी आप. It is resistant to chemo. इसमें आपको क्या करना पड़ेगा? सर्जरी. मोस्ट लाइकली यू रिमूव द यूट्रस. सर्जरी में आप क्या करेंगे? यू डू हिस्टेक्टमी, या अगर बहुत ज्यादा है या वट एवर, इफ पेशेंट इज नॉट सर्जिकली फिट, देन शी कैन गो फॉर रेडियोथेरेपी, बट इट इज इनसेंसिटिव टू कीमो. द 2 points you have to keep in mind. Beta HCG is not that much, it is localized, and it is insensitive to chemo, and surgery is the answer to treatment. Then metastatic disease, choriocarcinoma, है ना? वो तो metastatic choriocarcinoma generally goes to the different organs. Common site of metastasis is lung. Lung में commonly क्या मिलता है? कैनन बॉल अपीयरेंस। अगर आप एक्सरे कराएंगे तो बॉल रिंग लीजन्स मिलेंगे, कैनन बॉल। और कहाँ कहाँ स्प्रेड कर सकता है कोरियोकार्सिनोमा? लोकल एरिया में, वजाइना में, पेल्विस में, और डिस्टेंट में लिवर में, ब्रेन में, ऑल दोस थिंग्स। So lung is visible in 80% of the lung involvement is seen in 80% of the cases with GTN. And if lungs are involved, then patient might present with all these symptoms: chest pain, cough, hemoptysis, dyspnea, or respiratory symptoms. It indicates involvement of lung. Now, फिर आप कोरियोकार्सिनोमा यू विल डायग्नोज एक तो बीटा एससीजी लेवल से, और आपने स्कैन कराया उसमें आपको ग्रोथ दिख रही है यूट्रस में, all these things. Then classification of GTN, just in short, stage 1 में क्या होता है? ट्यूमर इज confined to uterus. Stage 2 में क्या होता है? In the pelvis. It remains in the pelvis, in the genital tract. Stage 3 is pulmonary metastasis. The diagnosis is based on high SCG level in presence of pulmonary lesions. Stage 4 is advanced. Spread to other organs. ये रिस्क स्कोरिंग है, आपको याद नहीं करना है, जस्ट आपको नाम पता होना चाहिए। WHO रिस्क असेसमेंट स्कोर फॉर GTN, क्योंकि व्हाट वी ट्रीट द पेशेंट बेस्ड ऑन दिस ओनली। ट्रीटमेंट हम ऐसे ही डिसाइड करते हैं। कोई पेशेंट हमारे पास GTN की आती है, देन हाउ डू वी डिसाइड उसका ट्रीटमेंट? वी डू द स्कोरिंग। अगर वो लो रिस्क है, देन वी गिव सिंगल एजेंट कीमोथेरेपी। सिंगल एजेंट में मिथोट्रेक्सेट और एक्टिनोमाइसिन डी, दोनों में से कोई भी एक। अगर उसका स्कोर लो आता है, स्कोर लो इज लेस देन 6 स्कोर है, देन इट इज लो रिस्क, और हाई लेस देन 7, और इफ स्कोर इज मोर देन 7 इट इज हाई रिस्क। अगर हाई रिस्क आ रहा है, स्कोर ज्यादा आ रहा है, तो आप उसको क्या देंगे? मल्टी एजेंट थेरेपी। तो कॉमनेस्ट इज इमैकोरेजी। तो अगर दैट इज वेरी इंपॉर्टेंट कि आपने अगर रिस्क स्कोरिंग अच्छे से नहीं करी तो ट्रीटमेंट विल बी रॉन्ग। उसका रिस्क हाई था और आपने उसको सिंगल एजेंट दिया, तो दैट विल नॉट रिस्पॉन्ड। उसको मल्टीपल एजेंट चाहिए थे फॉर ट्रीटमेंट। सो दैट इज वेरी इंपॉर्टेंट। तो रिस्क स्कोरिंग इट इज गिवन इन एवरी बुक, यू कैन सी। उसमें बस क्या क्या देखते हैं वो? पेशेंट की एज, एंटीसीडेंट प्रेगनेंसी, कि अब GTN हुआ है तो पहले मोलर था, उसको अबॉर्शन था, टर्म प्रेगनेंसी थी, इंटरवल कि कितने दिनों बाद उसको GTN हुआ है, 4 months, 6 months, 12 months, all those things. Beta HCG level, blood group, size of the tumor, and site of metastasis, number of metastasis. All these things you keep in mind by scoring. So scoring is important. आपको बस पता होना चाहिए नाम, because definitely आप लोग करेंगे नहीं, you will refer the patient. But just for your knowledge, you should know. So कोई भी पेशेंट GTN का आएगा तो हम लोग बेसिक इवैल्यूएशन करते हैं। वी डू द बेसिक हीमोग्लोबिन, WBC, TLC, LFT, KFT, बिकॉज कीमो देनी है आपको। कीमो से पहले यू हैव टू सी रीनल फंक्शन उसका ठीक होना चाहिए, लिवर फंक्शन ठीक होना चाहिए, एंड देन डेफिनेटली CT स्कैन टू सी कि आप कहीं और स्प्रेड तो नहीं है, कहीं और मेटास्टेसिस तो नहीं है, एंड अल्ट्रासोनोग्राफी और CT स्कैन। उससे आपकी स्कोरिंग पता चलेगी अगर स्प्रेड है या साइज क्या है यूट्रस में ग्रोथ का, और कहाँ कहाँ पे और स्प्रेड है, तो उससे आपकी स्कोरिंग पता चलेगी। अगर सब जगह स्प्रेड है, ग्रोथ का साइज बड़ा है, तो आपका स्कोर बढ़ जाएगा। देन यू हैव टू डू मल्टी एजेंट थेरेपी। तो ट्रीटमेंट इज एज वी डिस्कस्ड, सिंगल एजेंट में मिथोट्रेक्सेट और नाउडेज एक्टिनोमाइसिन डी इज ऑल्सो गिवन। उसमें यू गिव ऑल्टरनेट डे मिथोट्रेक्सेट अलॉन्ग विथ फोलिनिक एसिड, है ना, टू अवॉइड मिथोट्रेक्सेट टॉक्सिसिटी। तो आप 7 days तक देते हैं ऑल्टरनेट, एक दिन मिथोट्रेक्सेट, एक दिन फोलिनिक एसिड, मिथोट्रेक्सेट फोलिनिक एसिड फॉर 7 days। तो आपने एक साइकिल दिया, एक साइकिल के बाद फिर आपने बीटा HCG कराया। अगर फॉल हो रहा है तो देन यू माइट नॉट नीड टू गिव अनदर साइकिल। अगर लग रहा है फॉल नहीं हो रहा, स्टैटिक है, तो आप उसको रिपीट कर लीजिए ये साइकिल दोबारा। व्हेन द डिजीज इज रेजिस्टेंट टू सिंगल एजेंट थेरेपी, अब आपने उसको सिंगल एजेंट 2 या 3 बार दिया, फिर भी उसका बीटा HCG प्लेटू कर रहा है या राइज कर रहा है, देन इट इज टाइम टू स्विच ओवर टू मल्टी एजेंट। तो आपको मल्टी एजेंट पे स्विच ओवर करना पड़ेगा। सो ऑल पेशेंट विद हाई रिस्क GTN शुड बी ट्रीटेड विद प्राइमरी इंटेंसिव कॉम्बिनेशन कीमोथेरेपी और कुछ केसेस में we might need to give radiotherapy also. अगर brain में metastasis है, कहीं और metastasis है, in that case. So imaco is a preferred primary treatment with metastatic disease. Imaco में कौन सी ड्रग होती है? Etoposide, methotrexate, actinomycin D, cyclophosphamide, oncovincristine, है ना? So these are the drugs. कभी पेशेंट इमैको से भी रेजिस्टेंट होता है. देन यू स्विच ओवर टू अदर कॉमनली यूज्ड इज ईमा-ईपी. उसमें वी यूज इंस्टेड ऑफ सी और ओ वी यूज इटॉप्साइड एंड सिस्प्लेटिन. एंड इसमें सेम इज प्रेगनेंसी शुड बी अवॉइडेड फॉर 1 year आफ्टर कंप्लीशन ऑफ ट्रीटमेंट. देन फॉलो अप इज वेरी इंपॉर्टेंट. फॉलो अप में लो रिस्क जीटीएन में आप कैसे करेंगे? वीकली एससीजी कराएंगे टिल दे आर नॉर्मल फॉर 3 consecutive वीक. मोलर में कैसा था? हर वीक कराया, जब तक नॉर्मल आ गया उसके बाद मंथली कराएंगे फॉर 1 year. लो रिस्क में क्या है? आपने हर वीकली कराया, नॉर्मल आ गया, नॉर्मल आने के बाद जब तक 3 वैल्यू नॉर्मल नहीं आएंगी तब तक कराएंगे. एंड उसके बाद क्या करेंगे? मंथली, फिर 12 months. मोलर में 6 month के लिए करते हैं, इसमें 12 months. और हाई रिस्क जीटीएन में कैसे करते हैं? फॉलो वीकली एससीजी अंटिल दे आर नॉर्मल फॉर 3 consecutive वीक फॉलोड बाय मंथली फॉर 24 months. 2 साल तक फॉलो करते हैं. So SCG regression curve is a primary basis for determining need of additional treatment. और कभी भी लगता है आपको SCG rise कर रहा है, plateau कर रहा है, तो आपको might be recurrent disease, तो आपको हो सकता है बीच में और कीमो देनी पड़े. In short about GTM, molar and ये benign and malignant. तो malignant तो definitely you will refer. आप मतलब आपको तक आएगा ही नहीं. Benign is the thing जो आपको diagnose करके catch करके आपको timely refer करना. So if you have any questions, we can discuss. Or if you want to add certain things which are not, you feel are not covered here, या you want to add for the house, तो क्या हो सकता है आप बताइए, सोच के बताइए. एक तो है इन्फेक्शन हो सकता है, एंडोमेट्राइटिस. एक होता है एवीएम हो सकता है. हार्मोन्स कैन हेल्प, क्योंकि कई बार होता है ना मल्टीपल डीएनसी ट्रॉमा होता है, जो ब्लड वेसल्स है ट्रॉमा से वो एवीएम बन जाता है. एवीएम आर्टेरियोवेनस मैलफॉर्मेशन. तो पेशेंट ऑन एंड ऑफ ब्लीड करती रहती है, तो उसमें आप प्रोजेस्टेरॉन दे सकते हैं, है ना? कंटिन्यूअस प्रोजेस्टेरॉन दे दीजिए, या अगर आप 20 कंटिन्यूअस दे सकते हैं फॉर 2 या 3 months. या आपने उसको मिप्रेट दे दिया, मेड्रॉक्सी प्रोजेस्टेरॉन एसीटेट 10 mg OD या 10 mg BD.
Acetic acid which comes in the market, and you add 95 ml of distilled water and you prepare a fresh acetic acid. Then the luolpidine I just told you, but probably this did not work very well. Then another thing, you had a session on the endometrial cancer yesterday. So did you learn the method of biopsy, how you are all doing the biopsy and what was taught? है ना? तो वो आप सब करते हैं या किया है या देखा है? किया भी है. So because not many people do endometrial aspiration, that's why I thought I'll get this cannula. So this is the 5-number cannula, and you should use a 20 cc syringe, a big syringe. So when the spoil one, I don't want to, because this is 75 rupees. Anyways, मैं दिखा देती हूँ. So this has to be actually detached from here. So either they cut or they just detach. Sometimes it's just detachable. Sometimes you have to actually cut. Scissor है क्या? यहाँ पर कहीं? And then the 20 cc, because it will never go directly into this. It will not create that vacuum. So for that it has to be cut. I'll just show once they get it.
Madam, we can use MBA.
Cannula is the same. Yes, you can use that, but then to attach to a syringe, you have to cut it, or in some of them it just comes out. And then if you attach this syringe, थोड़ा कम है, 4 mm नहीं, 5 is the best that goes. क्योंकि वो अगर अटैच हो जाती है आपकी अच्छे से
उसमें सेक्शन होता ही है
yes so only thing is so now when you attach it मिल गया मुझे मिल गया participant so you attach it and so that's why 20 that is 60 that will give you more pressure good pressure the only thing is leakage नहीं होना चाहिए and thin cannula लेना है क्योंकि dilatation नहीं करनी है so when there is a cervix you just go and enter into it inside and when you go and it is because it is snugly fitting when you will create the vacuum you create the vacuum and then if it is tight and then you keep moving it like this with the vacuum so for the same person to create the vacuum and to move is little difficult but you have to do it like that cervix has to be pulled and then the contents keep coming into it itself just like they happen for the MBA so those who are doing the MBA it's not so difficult because one has to pull the cervix that your assistant will do but you get inside and you create the vacuum and then you move it a little bit the contents will come so that is the advantage is being the overall sampling you know the whole cavity is sampled and all surfaces the superficial layer of endometrium is coming so you don't miss which you do when you do the curettage or something so this is about the endometrial aspiration कौन सा सिलेंडर syringe is bigger na that's what I am saying so but then it will create a better pressure some people try to do it with 10 ml kabhi nahi hoga you have to create a pressure so and advantage main है कि dilatation नहीं कर रहे तो painful नहीं होता है the main pain that happens is because of the os dilatation the internal os and this 5 mm or 4 mm will go very easily without dilatation यही main advantage है and disposable है ठीक है ये तो आपके उन्होंने फॉर्मलिन वाइल्स तो 6 का प्रॉब्लम वही है 6 बिना डाइलेशन जाएगा नहीं सबके में कुछ पे चला जाएगा तो इसलिए हमारे यहाँ भी नहीं आता है सप्लाई में तो फिर वो बाय करना पड़ता है या करवाते हैं बट आपके MBA सिरिंज में तो सारे हैं ना 6 से ऊपर ट्राई करके देखो मतलब 6 से some patients may go they will feel pain but see the normal एक तो ना ये कॉन्सेप्ट निकालो multiparity affects the external os not the internal os ये wrong concepts में मत करो os parasites what nonsense that's the external os not the internal os will be closed for every woman and it will cause pain if you get inside. So 6 mm may cause pain, in some it may go, they may have a better tolerance, so that's the difference. ठीक है? So this is the curette basically, and when you use, see the diameter of this will be around 6-7 mm. So when you enter with this, it causes the same this, they will cause pain, and then the trauma that they cause, and the infection that they cause, because you are scraping the. Now this is your punch biopsy forceps. The tip is such that this gets inside this, so the tissue gets trapped. And so when you see a cervical growth, which I was talking yesterday, you just have to go to the side of the lesion, wherever is the side, like here, and you pinch it like this here, and you take that tissue, right? And these are the swab sticks which any of your employees can prepare. That's not a big deal, you don't have to buy it. With the cotton, they can just prepare it for applying the acetic acid or the Levol side. Yeah. Not necessary. VIA alone is a screening. So when the lesion which appeared as to white, when you apply Levol iodine, that will not be stained. It will remain light yellow and the rest will become dark brown. So the color contrast is better in Levols, but the sensitivity, specificity of acetic acid is better. That's why villi is never alone a method of, is not considered. It has a lot of false negatives, false positives. So therefore, it is not considered, villi alone is not considered. As an adjunct you can use, but not a standalone. Alright, so now having done that, no more questions? We are through with it? Alright, so this I will take a little later because you did CA ovary today. So Dr. Renu has told you the clinical features and the diagnostic criteria and the staging. Did she tell the staging?
Yes.
Okay. So my job is only to tell you how to manage those cases. So more important, did she tell you how to decide whether it is a malignant or a non-malignant? She told you. So basically, when you have ovarian tumors, this is the main issue. Whether it is malignant or benign is one issue. Among benign also, among malignant there is a borderline ovarian tumor. Then among benign, they may be small, they may be big. So these are two categories. The other two are the other conditions which will present similarly. Like, what are the other differentials where presentation will be similar? So you have lot of functional ovarian cysts. The corpus luteal cyst, the follicular cyst, or the luteal cyst, luteomas that are there. So there are many other conditions which may be just an exaggeration of the physiological enlargement. So they are not disease. Okay. Then fourth category, there is another disease where you have ovarian enlargements which may be huge, like endometriomas. So that is not a tumor, that is not a benign or malignant, it is just a disease where ovarian enlargement is there. And a fourth condition is very common with us is tuberculosis. So there are a lot of tubo-ovarian masses which may be bilateral, which may be unilateral, which may be associated with ascites. If it is tubercular, if it is abdominal, pelvic, cox. So the presentation may mimic CA ovary. Right? So this is one important thing, that when you see a case, you should clinically and with the help of tumor markers and imaging, you should be able to judge what it is and then decide the thing. That is an important thing. So we cannot jump to say that because there is ovarian enlargement, it is ovarian cancer. We cannot jump to say that because it is ascites, it is malignant ascites. It can be tubercular ascites also. So these are the important aspects in the clinical diagnosis of ovarian cancer. So final diagnosis will come on histopathology only. But seeing that we cannot take everybody for a laparotomy. So we have to decide which patient to be operated or not to be operated. That is first. And second is, if to be operated, whether we can do laparoscopic surgery or we have to go for open surgery. Alright? So this is, therefore it is important. So every ovarian enlargement is not malignancy, and for every woman we do not go for a laparotomy. Some may be doing good with laparoscopic management also. So how we decide on that? Whatever ultrasound features she must have told you that they are more suggestive of benign, they are more suggestive of malignant. So if features of imaging and tumor marker both together are suggestive of malignant, then definitely it is malignant and you go for the treatment will be, now in that also, whether it is operable or not operable. हमारा clinical भी और इमेजिंग भी और ट्यूमर मार्कर भी मैलिग्नेंट की तरफ जा रहा है, मैं एक एक्सट्रीम से नीचे आऊँगी धीरे धीरे, तो तब हमें करना है सर्जरी, या वो सर्जरी के भी लायक नहीं है, अभी इतना एडवांस्ड है, वो कैसे पता चलेगा? वो आपका CT स्कैन बताएगा. If the disease is confined to the ovaries or extending to the uterus, tubes, pelvis, abdominal cavity, still you can go for surgery. But if it is invading, say, the bowel wall, if it is invading the bladder, or if it is involving the root of the mesentery, which is, a long area, or there are metastases in the liver, or there are pulmonary metastasis and there is pleural effusion. So if these features are there of distant metastasis, then, or bowel and bladder involvement, then you have to counsel the patient and you have to tell her that this may, either they are willing for complete surgery, removal of that segment of the bowel and the bladder, that is, they are kind of exenteration surgeries. Otherwise, such patients will do good by giving chemotherapy first. This is called neoadjuvant chemotherapy. So those who are not operable due to extensive disease, we take them for neoadjuvant chemotherapy. We give them 3 cycles and then we assess again, both clinically and by imaging. And when we find that now it is a resectable disease, then we do the surgery and we give 3 more cycles of chemotherapy after that. So that is for advanced malignancies. Alright? If it is operable, then primary surgery is the ideal thing. So if it is operable, depending upon obviously थोड़ा सा expertise of surgeon भी होता है, तो फिर हम, but primary surgery is always considered a better surgery because you will resect all the disease. So you do a, इसको हम बोलते हैं cytoreductive surgery, primary surgery. तो जो ऑपरेबल है उसको हम प्राइमरी cytoreductive surgery के लिए लेते हैं, जिसमें uterus, bilateral tubes and ovaries, whole of omentum, and we take any metastatic deposits if they are there in the peritoneum or anywhere. So that is a primary cytoreductive surgery, and our aim is to leave no macroscopic disease, zero residual disease. तो जब ये करके फिर we treat them by 6 cycles of chemotherapy in a go. ठीक, तो ये हो गया operable disease. Then there could be a disease which is malignant, but it is a very early stage disease. It is just confined to the ovary, not going elsewhere. In those cases, depending upon the age of the patient, the fertility status of the patient, we may offer her fertility preservation surgery. That is, we go in, we just remove that diseased ovary and the tube. So unilateral salpingo-oophorectomy. Other ovary appears normal, tube appears normal, we leave it, we leave the uterus also. But this is not the end. We have to do the omentectomy because microscopic disease, if present, will suggest upstaging of the disease. Also, we take random peritoneal biopsies from the whole peritoneal cavity and we remove the lymph nodes, that is pelvic lymph nodes, again for sampling, that if they are positive microscopic disease is present, patient will have upstaging of the disease. So this is called a staging laparotomy. ठीक है, तो सबसे एडवांस नॉन ऑपरेबल हो गया कीमो फॉलोड बाय सर्जरी, ऑपरेबल है बट एडवांस्ड है तो प्राइमरी साइटोरेडक्टिव सर्जरी, अर्ली स्टेज है confined to ovary है सिंगल ओवरी, then in those cases fertility preservation may be offered. अगर वही 45 years old में तो नहीं हम fertility preservation करेंगे, but अगर वो young है तो हम वो करते हैं. But that is a staging laparotomy. You remove lot of other things to rule out any microscopic disease which is not picked by the imaging. So this is for malignant tumors. But if by your imaging and by your tumor markers it appears to be benign, तो क्या करेंगे? तो भी ट्यूमर तो निकलना ही है, तो सर्जरी ही होगी. Again, if family completed 40-45 plus, then we can remove that tumor and the other side tube and ovaries we may leave the uterus if it is benign, right? हमारे पास हमारे हॉस्पिटल में फ्रोजन सेक्शन की फैसिलिटी है तो हम लोग उसको उसी समय भेज देते हैं and we get in half an hour or something the report of the more confirmation, then only I will leave the uterus and I will not do a staging laparotomy also. I mean, I will not do omentum and all that. So when we are in doubt, frozen may help and change our decision. More so if it is a younger patient, because in young patient I don't want to do a hysterectomy for a benign ovarian tumor. right? So again, tailoring the surgery according to the need of the patient. So if it is a young patient with a single unilateral ovarian mass, then it is better to send it for frozen. Take that in knowledge. अगर वो malignant आ जाता है, तो भी I may not remove the tubes and ovaries and the uterus, but I will do the omentectomy, peritoneal biopsies and all that, and the lymph nodes. So that is for the benign tumors. Now benign tumors किसको सर्जरी करना है, कितने बड़े को? 6 to 8 सेंटीमीटर के ऊपर जो है वो डेफिनेटली निकालना होता है. उससे छोटा है, बेनाइन है, लग रहा है आपको, तो हम फॉलो कर सकते हैं 3 months में, 6 months में. अगर साइज बढ़ रहा है तो निकालना पड़ेगा, अगर नहीं बढ़ रहा है तो वी कैन, आई मीन फॉलिकुलर सिस्ट या कॉर्पस ल्यूटियल सिस्ट कई बार रिग्रेस कर जाती हैं अपने आप से. सो the cutoff is 6 centimeters. Below that only you can do this kind of conservative approach. I mean follow up, and all your markers are negative, all your imagings are negative, for they don't show any signs of, and patient is asymptomatic, not having much problem. Then and she is young. So lot of criteria to say that okay we will observe. But anybody who is 40-45 plus, then there is any mass, better to remove, because risk of ovarian malignancy increases after that age group. So that is how we have a gross planning of the disease. Now young patients where we are in doubt, थोड़ा सा मार्कर बढ़ा है, प्रॉब्लम क्या है? जो मैंने 2 डिजीजेस बताए, the endometriomas and tuberculosis, दोनों में CA-125 बढ़ता है. So these are the most difficult cases to take a decision what to do. And she is a young girl, say 28, 32, है ना? And she, obviously I also don't want to give that big scar to her. So then I do a laparoscopy and I assess. And then if it was raised marker, then I, instead of doing a cystectomy, I will do an oophorectomy. Put it in a bag and then take it out. I do not allow it to rupture inside and do not let it leak at all. So those things can be done. Sometimes they turn out to be borderline tumors. Right? My aim is that it doesn't drop down. Then there are conditions like dermoid cysts. This is a benign disease, but it is a complex mass. उसको आप सिस्टेक्टमी करना मुश्किल होता है ना? डर्मोइड का जो वो रॉकेटेंस्की ट्यूबरकल होता है ना, जहाँ वो सारा सॉलिड एरियाज होता है, वहाँ पर निकालना डिफिकल्ट होता है. सो अगेन डिपेंडिंग अपॉन हाउ बिग इज द साइज, वेदर यू कैन रिसेक्ट इट, लीकेज नहीं होना चाहिए. सो वी कैन डू लेप्रोस्कोपी इन दोज केसेस ऑल्सो, बट अवॉइड लीकेज विच विल, दोनों डर है. अगर मैलिग्नेंट निकल आया तो वो स्पेल हो जाएगा, एडवांस हो जाएगी डिजीज, ये डर है. और डर्मोइड के केस में वो सारा जो मटेरियल है ना, वंस इट कम्स आपके स्कोप पे लगेगा एंड इट विल स्पॉइल योर विजन, कर नहीं पाएंगे आप आगे. सो डिफरेंट टाइप्स ऑफ ट्यूमर्स में डिफरेंट प्रॉब्लम्स, एंड उसके अकॉर्डिंग हम लोग डिसीजंस लेते हैं. सो गुड प्री ऑप इवैल्यूएशन इज मोस्ट इम्पॉर्टेंट, दैट वेदर टू ऑपरेट और नॉट, इफ टू ऑपरेट, ओपन और लैप, if open or lap, whether conservative or radical. ओपन लैप में तो रेडिकल नहीं करते हैं, अगर रेडिकल की ज़रूरत है तो ओपन ही करते हैं, बट ओपन के बाद ज़रूरी नहीं है कि आप सबका रेडिकल कर दें. ठीक है? सो मोटा मोटा ये है ग्रॉस, जस्ट फॉर योर नॉलेज. एंड व्हाई आई ट्राई टू एक्सप्लेन इट लाइक दिस टू यू पीपल ऑल्सो, बिकॉज पेशेंट्स कम टू यू मेनी टाइम्स, यू गेट टेम्प्टेड कि ये तो हम कर लेंगे, फिर आप खोल लेते हैं, फिर आप फंस जाते हैं, फिर आप बंद कर देते हैं, फिर आप हमारे पास भेज देते हैं, क्योंकि हमारे पास ऐसे बहुत सारे आते हैं. ओपन क्लोज हिस्टेक्टमीज भी आती हैं, खोला था हिस्टेक्टमी के लिए, नहीं कर पाए, बंद कर दिया, फिर भेज दिया. सो अ गुड प्री ऑप असेसमेंट इज इम्पॉर्टेंट. एंड सेकेंड थिंग इज दैट जो फैसिलिटीज़ हैं हम लोगों के पास, फ्रोजन की है, ये वाली चीज़ें सब जगह नहीं होंगी. CT, MRI सब प्राइवेट में हो जाते हैं, बट कोरिलेशन मैं तो अभी अपने यहाँ भी देखती हूँ, एट मेनी टाइम्स व्हाट आई सी ऑन द टेबल एंड व्हाट वाज देयर, डिफरेंसेस होते हैं. सो इट इज़ no single thing is, final. Clinical, imaging, tumor markers. तीनों को समझो पूरा and then take a decision. And patient's needs. Right? So I think I will stop here. Just tell you this much. But we'll invite questions if you have in your mind. That will be better. That's why I don't prepare slides for this, because I know you don't need to learn how to manage CAOV. But you need to learn that which is CAOV and which is not. And if it is, then what? How will it be managed later? So you counsel your patient कि वहाँ जाएंगे आपका फिर ये होगा and जैसा वो बताएं वैसा करिएगा. Another problem that we face, patients come and say कि उन्होंने कहा था कि सर्जरी करनी है, अब वो सुई वहीं अटकी है. अब जिसने कहा था उसको तो सर्जरी करनी नहीं आती, उसने तो की नहीं. तो इतना स्ट्रॉन्ग को देकर नहीं भेजो कि आप जाओ वहाँ सर्जरी हो जाएगी. Let us decide what is to be done. But this happens. And it is difficult to counsel against what has been counselled before. So give us that freedom to take our decisions when they come to us. Okay. Now, so ovarian carcinoma and tuberculosis. This is a very good question. So when do we suspect? See, in ovarian tumors, ovary will be enlarged. So usually it will be, so imaging should help. It may be unilateral. If it is unilateral, more likely to be ovarian, and it is ovarian enlargement. In tuberculosis, it will not be the ovary which gets enlarged. It is a tuber-ovarian mass because of hydrosalpinx enlarged in that. But that eye, for the person who is doing the ultrasound or the CT or the MRI, is important. Mostly bilateral होगा. दोनों में bilateral हो सकते हैं, but अगर आपको bilateral masses मिल रहे हैं, adnexal masses which are not very big, छोटे ही हैं. Tuberculosis में कभी आपको 10 into 10 सेंटीमीटर नहीं मिलेगा. ठीक है, हाइड्रोसैल्पिंग्स हुआ भी और कुछ एडेजन को करा के वो 5-6 सेंटीमीटर वाले bilateral complex masses अगर मिल रहे हैं, ascites है, reproductive age group है, not menopausal. ठीक है? Then I will first think of COX. साथ में infertility मिल गई, very good. ठीक है? So these are the things. अब confirm कैसे करेंगे? Confirm ऐसे करेंगे कि आप ये ascitic cap fluid भेजिए और उसमें ADA level देखिए. ठीक है? आपने cytology की, malignant cells नहीं आए, ADA कर लीजिए, बढ़ा हुआ है तो ये COX की तरफ. ठीक है? So these are some of the ways to. So mostly we won't like to open a COX, not at all. है ना? Never. मतलब अगर COX खोल दिया तो बहुत बड़ी गलती कर दी. है ना? तो इसलिए ये question important है. Younger patients, bilateral masses, not so big masses. Marker raised होता है CA125 पर बहुत ज़्यादा नहीं होता उसमें जितना. But then मैं उसको नहीं कहूँगी 100%. बहुत सारे CS में भी उतना रेज नहीं होता जितना वो रियली एडवांस कैंसर होता है, तो कह नहीं सकते. बट फिर भी और क्या होगा बाकी. चेस्ट देखिए, देयर मे बी फीचर्स ऑफ कॉक्स इन द चेस्ट एक्सरे. कुछ लिम्फ नोड्स देखिए. मेटास्टेसिस लेस लाइकली होता है CA ओवरी में. लिम्फ नोड मेटास्टेसिस इज लेस कॉमन. ट्यूबरक्लोसिस में लिम्फ नोड्स एनलार्जमेंट विल बी मोर कॉमन. तो ये छोटे छोटे डिफरेंसेस हैं, बट आप अगर एक उस पॉइंट ऑफ व्यू से देखोगे पेशेंट की सारी चीज़ें तो मिल जाते हैं. Someone else has prepared the slides, but again, see, overall, मैं ना भी slides चलाऊँ, vulval carcinoma is particularly, again, if somebody is coming with bleeding, somebody is coming with a growth in the genitalia, then obviously you must examine. Problem is that many times people just get a scan done and they don't examine. Now this examination, you don't even need to be a gynecologist for this. It is external. Even all MBBS should at least have a look at the genitalia and see if there is a lesion. Why should we get advanced vulval carcinoma? It is on the external aspect of the body. But we do get, because one, the patient doesn't want to show early, And two, when she reaches a doctor, everybody doesn't want to have a look, because obviously I understand examining the hands or the face is easy, but then we should not miss that. So the purpose to add this is only that much. We'll go through with the slides. So it is one of the rare cancers, but if you ask us, we get about 5-6 cases per year, so it's not that uncommon also. And as I said, advanced cases. There is no screening test that is available for this, and many patients, they have lichen sclerosis, or the cause is again HPV, just like this cervical cancer. So it is human papilloma virus related cancer, though there are some non-HPV related also. So HPV related disease is seen more in the younger and maybe multifocal. So if somebody is having this thing, and also one of the risk factors is radiation therapy. So women who have been treated with CA for CA cervix may have simultaneously, or later on they may develop CA vulva also. So the symptoms: patient will present with vulval itching, irritation or pain, some lump or bleeding, and this is irrespective of the coital, no correlation. It's not a post-coital bleeding. It will be bleeding off and on anytime, dirty discharge. Color changes maybe there is no growth, but there is only a color change. And she doesn't recognize it, she doesn't come, but if she's coming with itching and all, do an examination, see if there is a lesion there. Patient who presents with pruritus or pain and where cancer is not immediately suspected, at least use a period of treat, watch and wait as a method of management, but this should include active follow-up until symptoms resolve. So, but if you see a lesion, it is better to biopsy. The point is that if you see a growth, it needs to be biopsies. If you see a discoloration, which is associated with some symptoms, either the dermatologist sees it and rules out some infection or some kind of this thing. Otherwise, there will be a biopsy that should be done. So, symptoms we have said: lump, swelling, pain, soreness, mole that changes shape or color, visible open growth, thickened, raised, lighter or darker patches of skin. So, this skin discoloration, change in the color, change in the texture, these are all. Now, if you see a growth, this is a growth, right? Here, the labia minora is kind of thickened and swollen, but this is a growth that is there. So, irregular fungating growth, irregular ulcer or a lump, or here the metastasis is to the inguinal node. So, simultaneously palpate the inguinal nodes, and if they are palpable, it means it has metastasized also. One side, both sides or midline, they will have a change in the management. So, these are the stages. So, early stage disease is a small, less than 2 centimeter and above, involving the vagina is stage 2, and 3 is not the lower vagina but the upper vagina and the perineum, and then metastasis obviously. So, diagnosis will be by a biopsy definitely, and histological types, as we said, mostly it will be squamous cell carcinoma, HPV related, maybe non-HPV related, and उसके further types होते हैं. आपको ज़्यादा जानने की ज़रूरत नहीं है. बाकी differentiation जैसे सारी malignancies का grade 1, grade 2, grade 3, depending upon that will come the prognosis. कौन सा कैसे respond करेगा. So treatment is mainly surgical in these cases. So it is we call it modified radical vulvectomy. So what we say modified because nowadays they consider that only the part that is involved with a good margin of 1 to 2 centimeter has to be excised from all across, surrounding as well as in the depth. So you remove that, send it for histopathology. If your margins are clear, she is treated. Usually unilateral disease में एक ही साइड का है उतना ही करते हैं, बट साथ में lymph nodes निकालते हैं, inguinofemoral. Again, that is to rule out microscopic metastasis. So it is vulvectomy plus bilateral inguinofemoral lymphadenectomy. That is the surgery for this. So stage 1A तो removal हो गया मैंने उसको. Early stage will be the vulvectomy. Advanced stages
This I have already told you. Sentinel, I'll just come to. So advanced cases में क्या करेंगे? If it is not resectable, it is involving the bladder. Urethra gets involved many a times, you know. If it is just the lower third of the urethra, it can be excised. But if it is more, then maybe these patients first go for radiation and then, if required, excision after that. So chemoradiation for advanced stage disease where the bladder or the bowel involvement has been there, and bladder through the perianal route and bowel through the perianal route and bladder through the urethra. So it's a local spread. And if the lymph nodes are already enlarged, metastatic, and they are also bursting open, this is really an advanced disease. We have at times had cases where there were maggots in that carcinoma. I really remember that lady. And first we had to do all that cleaning and all, and then we took up the patient for surgery. So they are so neglected. Women do not want to come out with their problems. In the villages, they will not even talk about it. And you know, they reach such advanced stage. So therefore, all doctors need to know about these things, right? So what is sentinel node biopsy? I didn't want to, she has written it in these slides, so it's okay. Sentinel is, instead of doing all the lymph nodes, you just inject a dye around the tumor, and the node that gets stained, that is the first node which takes the drainage. So if you remove just that, that will also tell us if that is negative, it means all are negative. That is the concept of sentinel node biopsy. So now that has come up very well in CA vulva, in CA cervix, in CA endometrium. It has come very well. Only thing is that the dye that is there and the camera with which we see is not available everywhere. Even we do not have it. The indocyanine green dye is considered the best, and the gamma camera is required for that. So, but I have been doing with methylene blue dye, which we can see with the naked eye, and we have worked on this and we have published also with it. So, these are alternatives but not the right alternatives. So, these are the newer advances in management of all cancers that are coming. So, this is a nice picture of the indocyanine green. You will be happy to inject it and then wherever it is. So, and then adjuvant therapy will depend if the margins are not clear. So, if your margins on histopathology say that margin is, they say that at least 8 mm clear margin they should get on histopathology. So, if it is not there, either you go for a second resection or you give adjuvant radiotherapy. Also, if your margins are clear but the nodes are positive, then you have to give adjuvant radiotherapy. So, that is the treatment of CA vulva. Advanced, I have already told you that you can go with neoadjuvant chemoradiation and then going for surgery. So if the lesion still remains, then they come to us later on for removal. Recurrent disease, they have all to be on follow-up. Every 3 months they should follow, and anytime the disease comes back again. This is one disease where again a surgical resection can be done for a recurrent disease also. And we have done, so in follow-up I have. So in follow-up we have to see that only, that the disease is, you just do an external examination, palpate the lymph node, so if it is there or not. It will be rare that the metastasis is seen first and local disease is not there. It will be less common, but if whenever they come for follow-up, we do a general physical examination looking at all lymph nodes and abdomen and the local genitalia. You know, in times to come, it may happen, there are talks in the government that they don't want to shift even chemotherapy to district level, which we refused completely. But a follow-up of these patients, because we are doing surveillance when we treat them, they come there to come from far off. So I think at least that follow-up you should get, you know, acquainted with what all to be seen. That's why I kept one session on surveillance. So that at least the nearby doctor should be able to do, and then only when they find something they can be sent back to us. Okay. So maybe now I'll just tell you about the surveillance part that she was asking. So for most cancers in general, the surveillance is in this setting, that because recurrences occur mostly in the first 2 years. For first 2 years, they are called every 3 months. And every time they come, you have to do a complete history taking, any symptoms related to the cancer that she had or any other symptoms. Because
it is not just the recurrence of the cancer, but other issues also. As I said, if she's having pain, if she's having loss of appetite, if she's having any vomitings or any of those issues, which may be because of the chemotherapy or because of the general disability, you have to treat that. Symptomatic treatment has to be given for that. And regarding the recurrence, you have to, of course, take the history and examine thoroughly, in which lymph nodes, chest, abdomen and the genitalia examination are important. In CS cervix, if only surgery was done, then we can follow with cytology, because if there will be a disease recurrence, it can be picked up by that. But if it was due to radiation, then you can't do that, because radiation induced changes will be there, you can't see the cytology very well. So local examination, if there will be a growth, you can see the growth, you have to biopsy that. So for vulval, for cervical, it will be a recurrence will have to be biopsied again. For ovarian cancer, if there is, because we have got markers, but we don't advise markers on each visit. Each visit is only clinical examination. Maybe once in a year or twice in a year, you can get one ultrasound scan to look for any lesion, and similarly the CA125. So once in 6 months or 1 year, you may do the imaging and the tumor marker, which if present, if positive, then you do a more detailed examination, where is the lesion, whether you are finding a lesion or not. So that is the purpose of doing the surveillance. So first 2 years it is close follow-up every 3 months. The next 3 years it is 6 monthly, every 6 months. And after 5 years it is annual follow-up that should be there for all women, they should come. Including the GTN cases, which may actually get pregnant also and have deliveries also. And among the CA ovary, probably, I don't know if Dr. Renu talked about germ cell tumors. Did she talk about germ cell tumors? So all that I also talked was epithelial ovarian cancers, but the germ cell tumors are more common in the younger age group, and there we usually do fertility preservation surgery, or even the borderline tumors, and there it has to be a long follow-up, because these are young girls, 20, 30, maybe less than 20 also, 18 years, 16 years. And then the follow-up will be kind of till they complete family, and then we have to see that they are doing well, whether they need a completion surgery after that or not will be. So they need a much longer follow-up. So these are the most important aspects of surveillance. The slide is not there, I might be having, but maybe you all are feeling tired now, it seems. So I would not like to teach more than that. If you have questions, you can ask.
Dr. Ma'am, sir.
Dr. Kamlesh, Dr. Kirti Jain,
इधर देखिए इधर
Dr. Sapna Gupta, Dr. Mohammad Rafiq Ansari,
इधर देखिए मैम
Dr. Surabhi Singh, Dr. Shafrina Zamal, Dr. Neetu Sharma Mala,
एक मिनट मैम
Dr. Bagita Singh,
इधर देखिए मैम
Dr. Adarsh Sachan, Dr. Soma, Dr. Anil Kumar Yadav, Dr. Rupam Saror, last Dr. Rachna Singh. अब एक ग्रुप में फोटोग्राफ
एक मिनट आप थोड़ा सा इधर आइए एक मिनट बस 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 सामने देखिए सब लोग